Hello and good afternoon. Those who believe in the spiritual healing process will vouch for how a positive, empowered, and awakened individual can help achieve more significant healing outcomes by striking a chord with ourselves, our surroundings, and all that impacts our health and well being. Patient centricity in healthcare resonates with the same process. The difference here is that in a spiritual method, me is the center of the universe, while in a patient centric healthcare universe, patient is the center. Let's try to understand it in a simpler words. Suppose I encounter hypertension episodes and visit a doctor for help. What do you think will make me get better and stay better? In scenario one, the doctor just prescribes me a bunch of medicines which I need to pop at specific intervals. Or in scenario two, where the same doctor also strives to explain my condition, the causes that led to it, and the modification that will help me prevent this from worsening, and how the compliance or non-compliance to my medications will affect my health. I'm sure most of you will agree that scenario two sounds more empowering and assures good outcomes from the very hearing of it. Now let's add another aspect to it. What if the same doctor also speaks to my wife and educates her about regulating salt usage in the kitchen, or maybe encouraging her to nudge me for a morning walk every day? I may not like it at first, but this certainly helps me bring some systemic modification in my lifestyle and that of my family, which will eventually help me manage my hypertension much more effectively. In a word, this is what patient-centric healthcare is all about. You can visualize the similar process with even more freedom of choices for patients with many other healthcare problems, whether it's more commonplace disease like diabetes management, or a rather complicated treatment of cancer, or a knee replacement surgery, and so on and so forth. A patient-centric approach is how healthcare system can empower patients to be more conscious, caring, and contribute to their health and well-being. This also seeks to build a more participative partnership among patients' family, caregivers, and other stakeholders, including a community to support this process. And like raising a child needs a village, delivering patient-centric care requires an empathetic approach and a proactive participation of the entire healthcare ecosystem, involving doctors, nurses, hospital managers, drug makers, and even government leaders planning for health for all. And of course, the transition to this approach also requires the committed push of patient advocates who believes no disease shall remain neglected and no patient shall be left alone. So ISW Council is proud to be one such advocate, and this made us convene today's this unique Patient First Summit, and also an award that strives to put the patient's interests and right at the center of our healthcare system. It will also recognize the visionary approaches taken by many care providers in nurturing patient centricity and preserving patients' rights, along with celebrating the arduous journey of many patient advocates fighting for this cause. So first, to understand where we stand when it comes to achieving patient-first healthcare in our nation and how it can be the cornerstone for building a Swasth and Ayushman Bharat, today we will be joined by some of the most eminent luminaries of healthcare with us. So let me welcome and begin today's session with Dr. Sanjay Kumar Agrawal, Professor and Head of Department of Nephrology at All India Institute of Medical Sciences, New Delhi. Dr. Kumar is championing the cause of kidney diseases prevention and care in India. He has been in the forefront of spreading awareness about these issues in masses, as well as sensitizing policymakers about this issue. We are also being joined by Dr. Suchin Bajaj, Founder Director, Ujala Cignus Healthcare Services, Dr. Bajaj is an avid healthcare entrepreneur and investor. He is associated with multiple health tech companies and as investors and board member and mentor. Dr. Bajaj is passionately working towards bringing quality tertiary care to urban poor and to areas that still lacks it. He has also been recognized for outstanding contribution to Ayushman Bharat scheme from the Government of India. We will be joined by Dr. B.G. Dharmanand, President of Indian Rheumatology Association, as well as Dr. Rishikesh Pai, Medical Director, Bloom IVF, and President-elect of Federation of Obstetrics and Gynecological Society of India, that is also known as FOGSI. So let me, I can see Dr. Rishikesh Pai has also joined us. So Dr. Pai is also one of the country's leading gynecologists, and is a pioneer in the field of infertility and IVF. Dr. Pai is a strong advocate of women's health and has been recognized with several awards for his path-breaking work in this area. So let me begin with Dr. Bajaj, maybe. Why I'm starting with Dr. Bajaj, because Dr. Bajaj is not only a doctor, but he's also managing hospitals. He's not only managing hospitals, he's trying to bring this care, as I said, to areas where tertiary care has been largely absent. Dr. Bajaj, what patient centricity means to you?
I think patient centricity is something that Mahatma Gandhi had said about, the reason for our being is that the customer is there. So if you look at the patient as the core of all you are doing instead of the hospital or the doctor, and make that the main purpose, that whatever you are doing, if you look back and see whether it is helping my patient or not, and only if it is, then you keep doing it. Otherwise you should neglect to do everything else, is something that is the core philosophy that we try to follow. Also, we try to instill in all our staff and all our doctors and our paramedics is that in case of any doubt on whether you should be doing something or not, just imagine at that very moment that if your father or brother or mother or sister was lying in that bed instead of this patient, what would you have done? It removes actually 90% of the doubt. So then you never say that, oh, this is not my duty, or GDA staff will come to clean you up, or a doctor will come to prescribe you medicines for your pain. I can't give you anything. At that time, you don't feel anything. Then if you feel that if my father was lying here, what would I have done? Then all the answers come very quickly and clearly to your brain and your heart. So patient centricity means removing that imbalance between the power in the transaction that happens on a day-to-day basis between medical and non-medical people. Usually the entire power in that transaction is with the doctor. The entire knowledge is there, the entire decision making capacity is there. You go to a doctor, you feel quite helpless and powerless because of usually the jargons they use. They use words like PTCA, CABG, lab chole, which you don't understand at all. And then they will tell you that this is the only way out for you and you have to get it done. So lie down and immediately we'll do it. Otherwise, if you walk out of this door, you'll die. So you have no power in that transaction and you feel so helpless. And then when the bill comes, of course, you have no understanding of what is in it, what is written, the procedures, the medicines, the tests, all are so confusing. It's like they're all written in Greek. So that is, I think, most of the reason that patients feel so helpless. And when an adverse outcome happens, they feel so angry. And on top of that, the problem is that in societies like ours and in US, the entire medical system is based on a fee for service model. So when a fee for service model is charged, then the patients feel that if any mistake is done, it is due to malice and not a mistake. And everything was done to earn money, and we were not consulted. We were not a part of that decision making. And that is why you have so much of angst and anger against the medical practitioners, particularly in societies where fee for service is present. So in the US, we have the maximum number of legal lawsuits against doctors. Does it mean that people in Europe don't make mistakes? Does it mean that there are no deaths in Europe due to medical negligence? It's not that. It's just that Europe is mostly a capitation fee model and US is a fee for service model. In India, since people don't have that much faith in the legal process, so they prefer on the spot justice. And that is why you have so much of cases of violence against doctors happening all the time, because people feel that, if you go to a court of law, then it will be like a 20-year process and we will not get any justice, so better to administer it immediately. So if the doctors and the staff and the hospitals truly feel that patients should be a part of the decision making process, they should participate in each and every decision, not just on interventions but also on the costs involved in that, then these incidences will reduce to a large degree and patients will reinstill faith in the medical system.
Okay, just a small, follow-up question. Does that mean, since you, kind of drew a parallel between, the US system and the way the Indian system is largely, kind of a copy of Indian system when we are, US system when we are, getting healthcare for a fee, in comparison to the UK or European systems. Does that mean that patient centricity as an approach is more desirous in systems which are working for fee, or it is something which is universal? It should be all across.
It is absolutely universal, but there is a desire and a need to demonstrate it more clearly where there is a fee for service model, because the innate trust is lacking in such a model. So in Europe and UK, even if you do not demonstrate it explicitly, there is an innate feeling that, okay, this is all happening for me. It's not about money. People are not earning out of operating on me. So they are trying to help me and they have no other purpose. But in a fee for service model, the purposes become muddled, right? People feel that the doctor is not here to help me, he's out here to earn money. And his main purpose is that. So you need to demonstrate it more explicitly that you are the center of my entire work and being, and money is just a side effect of what we are doing. It is not the main purpose of what we are doing.
Okay, so this requires, the more clear demonstration, and as a practice, it need to be followed everywhere. And I am sure it is, the whole healthcare system across the globe is shifting toward this model, and so is, happening in India also up to a certain extent. But yes, there's a long way to go. Dr. Sanjay Agrawal, in your area of functioning, and especially in a hospital you are working, the most glorious and the most crowded as well, the All India Institute of Medical Sciences. How do you, so Dr. Suchin Bajaj was defining patient centricity from his approach, and he's he's associated with the private healthcare system, which is many times is demonized in our country because of many reasons, and maybe very clear demonstration of patient centricity also. What is the situation, or what is the relevance of such an approach in a hospital like All India Institute of Medical Sciences, where people are not apparently paying from their pocket for everything, but at the same time, they would also not like to be subjected to all kind of, the procedures which they don't feel they need to get that.
See, from my perspective, I've got little different perception. You see, in a healthcare setup, obviously, whether it is professional or whether it is pharma company, whether policymaker, ultimately aim is that the patient should get benefit. So everything has to revolve around the patient. But you see, I would like to say a few things in relation to this. Number one is that in our setup, which I feel maybe in other departments also, but at least in my department, see, number of the patient we see in a limited period of time, what you started initially that explained to the patient in detail and explained to the wife of the patient and then explain to the father-in-law and father also about the seriousness of illness. In a practical sense, it is practically not possible. You see, we are forced to see, say, 100 patients in 3 hours, so we somehow, in reality, we have using expertise, but in this aspect have become a little bit mechanical. Second point which I want to highlight is the reality of the society is that the type of patient we see in All India Institute, at least 30-40% or maybe more are such patients that if I start explaining them about illness and seriousness and long-term outcome and long-term treatment involved, they are not interested. You can see on the face of the patient that I am speaking, but he is listening from one ear and passing on from the second. So he is either he is not able to understand because of his education and involvement. Current reality is that everybody is in a hurry. We see patient who will just open the door, enter, and he also want to get the treatment written, revised treatment and investigation form filled, and so that he goes. So he is actually involved in somewhere else. He has to go to his office or somewhere. So he is showing medical component for him for a large number of patients is a secondary. So he want to finish. He doesn't want to stay there for half an hour or 1 hour and sit calmly. And once his turn comes, you try to understand the seriousness. This type of a patient are in minority. Another third thing I want to say, which is very important, is changing, at least in a Western setup, that nowadays what we do is studies in clinical trial. The end point of the clinical trial was initially and is still to large extent are being planned by the professionals. That if we are using antihypertensive drug, then our endpoint is that how good blood pressure control is with the new drug as compared to the existing drug. But now the things are changing, even patients are also included, and now at least in nephrology, the endpoint in clinical trial, which is core academics, is shifting to the goalpost that endpoints are also being planned from a patient point of view. Say in terms of if I give example of a dialysis, then maybe in a dialysis for a clinical trial, we will be more interested in mortality of the patient at 1 year or 5 years. But once you talk to the patient, his main concern is fatigue after the dialysis. He is not concerned whether he is going to live 1 year or 5 years. Obviously, not that he is not concerned. But his immediate endpoint is that he should not get fatigue after the dialysis because that disturbs him maximum. So these things are very dramatically changing now. The patient groups are also being involved in nephrology clinical trial of the newer drug or the newer modality to have a perception that, look, what you are making an endpoint is actually not relevant as much as some other point from a patient perspective. He wants that his dialysis should be done, and after dialysis he walks through and goes home comfortably. Doesn't want fatigue that he want to stay for next half an hour before he is actually active to the extent that he start doing his work, whatever he is doing. So from that angle, time is not far when the even drug regulatory authority and those things will also start asking the clinician or the pharma company to include the endpoints which are relevant to the patient also. And in literature also, you will start finding these as a major component of endpoint.
Wonderful.
So
Thank you.
This is one major thing which has changing, and a lot of literature on various illnesses on endpoint like nephrotic syndrome, hypertension, dialysis, transplant. Say transplant, we say that for how many years that transplanted kidney is surviving. But patient think that he should be fit enough to do his routine work, quality of life should be better. Survival for him will come at 10 years. Till that time, he has to pass 9 years. And those 9 years should be good quality for him, not that he is surviving 10 years, but he is almost bedridden and just surviving, and his quality of life is not good. So by every angle, the healthcare should be patient-centric.
Thank you so much, Dr. Agrawal. Interesting point you have highlighted, that while the sheer workload itself on the healthcare professionals may not allow them to spend that much time to kind of practice certain aspects of patient centricity on day-to-day work. You're also mentioning that maybe the patients also are not aware about what all they should be mindful of, or what's all they should try to understand about their health. And I think that there also a lot of work need to be done. Along with that, multiple changes which you are saying are already kind of getting in play. Dr. Pai, apart from the women health general issues, your specialization is also on IVF, and this one area also requires a lot of kind of participation of the patients in the process. It is something where again the success rate itself, which may be the end point for the patient, as Dr. Agrawal was talking about, the different endpoints for different patients and providers are different, but at the same time, in the whole process, and since the process itself has certain kind of downsides also, need to be kind of have a very, very, I think, cohesive participation of the both patients and provider in that. How do you see this patient centricity being kind of respected or incorporated in your specialization, especially of this artificial reproduction?
Thank you, Kamalji. So basically what is happening now is that we are slowly becoming westernized, and with more westernization is coming more patient centricity, because patients are expecting a lot, through the digital media, through information. Consumerism is becoming very active, and they expect a lot. So there's a problem in this in a way, because our charges are Indian, but the expectation of the patients are Western. You understand? So we will have to create somewhere we'll have to achieve a midpoint, but I realize that midpoint is not possible. So we will have to somehow give in to this demand from the patient side, and we will have to become Western in our behavior, but Indian in our charges. So we will have to borrow into the profitability of organizations in the future. So if you come to ART, is a very important example where now legislation has also come in. So there are two ways in which one can evolve into a westernized kind of operation. One is voluntary way. The second is a legislative way. When a legislative way comes in, whether you like it or not, you have to follow the rules. So for example, the ART bill is a typical example. Last 1.5 months since there is an upload of the registry now, probably my organization will end up spending a lot of crores of rupees in trying to come to parallel with the legislation, because with the legislation has come a lot of grievance cell and the grievance mechanism. So whether we like it or not, we will have to comply to such a high level of performance, and for that high level of performance you need a lot of more employment, more equipment, etc., etc. So there is with patient centricity, as it becomes more and more, there will be more expenditure. So the profitability in healthcare is obviously going to go down. The second thing is the supply side. Yesterday I was sitting on a panel discussion where the chief of the Ayushman Bharat and Mahatma Phule of the Maharashtra state was talking to us, and he was saying there's a supply problem now, because suddenly a lot of hospitals have applied for the Ayushman Bharat scheme and there are no patients. Suddenly the patients have gone down. So there's a supply side also issue going on in healthcare. Look at Dr. Agarwal. He is saying that he sees 100 patients a day. I see 100 patients in a month. So Unfortunately, what has happened is a huge amount of medical practitioners who are highly, of course, we are all come from where? Where have we come from? KM Hospital, AIMS, all of us have come from teaching hospitals only, government hospitals, but we are in private practice where the footfall is not as acute as the government hospital. So government hospital doctors are over stressed and the private hospital doctors are twiddling their thumbs. So the government needs to balance this supply. They need to start saying, okay, Dr. Pai, you are also in KM for last 25 years. You are as good as a professor in KM hospital or a head of department of KM. Let us also give you some patients and finance you through the Ayushman Bharat scheme. And you also, so you get a good uniform care for everyone in the country. What is happening is there's a lopsided care. Our professors are overburdened and the private practitioners have not enough work. So there is a supply problem in our country. So this needs to be corrected by our authorities, our government, our thinkers, our leaders in medical industry. And finally, I would like to say that with the demand of westernization, this can only be solved by robotics and by computers. So a lot of our work, once the robots take over, if I tell a robot who is sitting in the OPD, listen, every patient that comes, you must tell him A, B, C, D, E, F, G, H. The robot will follow it. But if I tell my secretary to tell her, she'll tell it for the first two patients and after that she'll stop telling. My vision is I'm totally going to create more of artificial intelligence, more of dependence on machines to create that patient centricity, because patients, what they are demanding is engagement. They want to ask questions all the time. How does a human being answer those questions? So we'll have to go to robotics and artificial intelligence to answer these questions and satisfy their demand. Thank you.
Thank you so much, Dr. Pai. See, one of the very important aspect you have definitely, I think touched the very important point of, this lopsided supply, and that how the one side is overburdened while the other side, maybe I'm not saying they are sitting idle, but they may be having a lesser, flow of patients. And if this can be, kind of equalized some way, can give more time per doctor, per patient to, kind of involve, both parties in this process better. But more importantly, you have mentioned certain words, performance, resources, profitability, expenditure. It sounds so business. I am not into the business of healthcare, so for me, these are an important aspects to understand. So let me go to Dr. Bajaj. Dr. Bajaj is in the business of healthcare, and he started with that patient is the customer, and that we exist, or healthcare as a system exists for that customer. Dr. Bajaj, after hearing Dr. Pai, what I feel is apparently patient centricity seems to be something very costly affair. Is that so?
See, I'll just start with Dr. Pai's point, and then maybe we can naturally climb onto the wagon that you are trying to make us board. What is the reason why Dr. Agarwal is seeing 100 patients a day and Dr. Pai is seeing 100 patients a month? See, Dr. Pai is as qualified, so there is no problem about quality there, right? He is even, I think, more accountable. So accountability is not an issue. Accreditation, I am sure, is not an issue because all his centers are NABH accredited, so there is no problem there. He is available. He is himself saying, I'm sitting here twiddling my thumbs. So availability is also not an issue. So where does the issue lie out of the 5 A's of availability, affordability, accessibility, appropriateness, and accountability, the 5 A's of healthcare that we all keep saying? There's only one A that is different between Agarwal sir and Pai sir, right? That is affordability. It costs you 5,000 rupees to go and see Dr. Pai. It does not cost you that much. Maybe indirectly it may cost you even more to see Dr. Agarwal because you'll have to wait in line, you'll have to bear your disease, you'll have to have 10-15 days of waiting. You may need to stay in Delhi for all that time if you're coming from outside the city, but the direct cost is very low. So it all again boils down to that fee for service model. If Dr. Pai were not to charge that, or if the patient was not paying out of pocket and the government was a third party payer was paying for the patient or whatever, then I am sure Dr. Pai would have as much of a load as any other professor at KEM or AIMS, right? So this fee for service model is something that we keep coming back to again and again and again. And I am sure the government understands it, but we can't seem to find something that can bring out of pocket expenses, dissociate out of pocket expenses from access to high quality healthcare. This close relationship between your financial ability and ability to access high quality healthcare is something that drives US to spend $3 trillion a year on healthcare and still have worse outcomes than Cuba in many aspects of healthcare, right? They may be doing bypass surgeries on a 102-year-old for the fourth time. They may be able to do it, but their nutritional status of children will always be worse than Cuba, right? Because there is no incentive for a bypass surgeon to, make sure that children are nutritionally well. People want to do kidney bypasses. They don't want to sit in a village and educate people how to control your diabetes so that your kidneys stay healthy and you don't end up in kidney failure. One third of all diabetics in India end up in kidney failure. It is a humongous statistic. We have 77 million diabetics. Imagine one third of them will end up in kidney failure. So, do you think that having those kidney failure patients are more costly, or developing a model to have patient centricity and prevent that kidney failure is more costly? Whatever you spend on it, however machines you may train, AI, ML as Dr. Pai wants, or your ASHA workers upgrading, or your Ayush doctors involved in that, whatever cost you spend on training them to make sure that patient is at the center and preventive and primary healthcare is promoted, I think the cost will be always a fraction of what we are paying right now to treat all these complications and get these complicated patients into the hospitals and then treating them. So cost is nowhere in patient centricity. It will actually bring down costs by a large margin if we follow it on a day-to-day basis.
Uh, Dr. Bajaj, when you are talking about the actual cost being incurred on both aspects of healthcare, the way it is as of now, where patients or the people are mainly pushed towards tertiary care because there is a acute lack of any kind of holistic care at the primary preventive level. And then obviously the cost incurs more. And then you are also mentioning about how government hospitals may be incurring a more cost. Both you are talking about from the patient point of view, because loss of working days, loss of even maybe since the hospitals like AIMS get patients from across the country, travel, stays, and so many things involved, and also the waiting which is involved in this whole process. But along with that, or apart from that, there is also a heavy cost of that healthcare provision also. I'm sure you know the numbers, that the government per bed hospital, maybe more expensively managed than the private ones. Now, this is one aspect to it. And you are mentioning about, that if we are able to, kind of focus more on the preventive side, at primary, structure reinforcement and all, there is a possibility of patient centricity not being that costly. But I think what Dr. Pai was mentioning, that patient centricity in this system, the system which we are, living, where so we don't have primary, we don't have preventive. We have to go to some hospital when we develop, kidney disease, or for that matter, need to go for a knee replacement or a hip replacement, or maybe, for something like IVF. And in this scenario, is patient centricity, managing patient centricity expensive? Is it a costly affair? Can't it be achieved in both these models as it is?
So you speak of numbers. Numbers, I think, are in front of us. They're staring at us all the time. We just refuse to see those numbers, right? 91% of all spend on healthcare in India is not on healthcare at all. It is on sick care. Only 9% is on primary and preventive actual healthcare. So we spend 91% of all money spent in India on patients who are sick. They've already fallen sick, they're already out of our control, and we're just trying to manage their complications. So those numbers can be brought down very, very quickly. Also, even in sick care, if you feel that the numbers on ensuring patient centricity can become high, they may become high in the short term, but in the long term they will always give you much, much higher returns on money. Because even in sick care, patient centricity means reduced complications, reduced goof ups, reduced medical errors, which lead to the majority of expenses shooting up. So we've heard of horror stories like patients being operated on the wrong leg. There was this major story about a very prominent hospital in Delhi that operated on a wrong leg. We've heard stories of in IVF people getting mixed up. There was a movie about it as well very recently. So if patient centricity is the focus of our efforts, all these errors will be minimized, and actually if you see within a year or two, the costs of your hospital and for your patients will be much lower even in sick care.
Thank, yeah, Dr. Pai want to add something. Then I'll go.
I see. So basically, what I agree with Dr. Sachin, that we will, the initial costs are more, but subsequently the costs are reduced, because what happens is, because I'm also the administrator of the Foxy Manyata initiative, which is the upgrading of the nursing home, but it's on a voluntary basis. And I'm very happy to tell you that 1,500 nursing homes are already. So we have 16 standards. We tell them how to be better in their care, how the standards are. And now we are also talking with other institutes as well, like other accreditation areas. So I feel that what initially, yes, you will have more investment, but subsequently what happens is that patients will become more happier, word by mouth will be better. Oh, this institute is very good, it takes care of not only the technical part but other parts as well. Reviews will be better, and ultimately more footfall will come, and better there will be better and more profitability for institute. So in the long run, 100% I agree that patient centricity will give. Not only that, what will happen is standardization will become more acceptable to the international fraternity. Medical tourism increases. See, at present, if you compare, India is competing with Thailand. Everyone goes to Thailand because infrastructure is very good, and standardization. And standardization of cost is also there. Transparency is important also. Once all these things start coming into India in our healthcare, the cost per procedure may go down, but we'll do a lot more procedures, and we will all be profitable. And India is not only as the IT industry, but it will be the mecca of the medical industry as well. So patient centricity is the key to make India the medical mecca of the world.
Absolutely, Dr. Pai. Dr. Agrawal, you are there?
Yes, there.
So Dr. Agrawal, two aspects. One is Dr. Bajaj mentioned about something, the increasing load of kidney diseases. And the reason of mentioning that was how we can, kind of prevent these load, which ultimately become 100% 3R load on, professors like you, how it can be kind of reduced at the very beginning, and you are 77 million diabetic patients who 1/3 of them are going to eventually meet you sometime. Yeah, can be prevented at there itself. What is the solution you see? You have highlighted a very important practical problem that in 3 hours you may have to see 100 patients. What is your take that how in this resource crunched or maybe wrongly designed model, patient centricity can be restored, especially when it comes to patient experience, participation in the healthcare?
You see, I am often blamed is speaking the truth in many forums. All India Institute, I am here for last 35 years, and I have no hesitation to say that it's not a patient-friendly hospital. I mean, if I am there for 35 years, if I have to handle any situation and it takes time and energy, then patient, you see, I will give you one example. A lot many patient relation and patient move around the hospital to find out a place where they want to go. So it's a very small example that so many people are moving here and there, and actually if they know where they actually need to go and there is some direction shown or some help at entry point or those things which will help at least patient's satisfaction. Before I forget, I tell you some of the examples say you're saying from how this load can be decreased. You see, policy maker has made 23 All India Institute in the country. And out of that, 6 All India Institute which planned initially in 2011, at least out of those 6, 4 still are not having any nephrologists. So you forget about the rest 15 hospital of AIIMS-like institution. Now they don't call AIIMS-like, they call AIIMS itself and the city where it is there. So somebody needs to blame that why it is so that the government is still not able to fill up the post of the nephrologist. So what is the fun of making these AIIMS in different states? Very good idea, but you see the implementation. So if for example, we often give example of Bihar because institute see 40% patients of the institute comes from Bihar. And Bihar had got Indira Gandhi Institute of Medical Sciences, Patna for last 20 years. AIIMS Patna is there for the last, is one of those institutions started in 2011. But still for a very simple thing which can easily be treated in any one of these 2 hospitals or maybe many other hospitals in Patna, patient still comes to Delhi All India Institute expending a reasonable amount of money, utilizing the transport system and making transport system full of people, then staying on the footpath of AIIMS Delhi for days. What for? So there is something which needs organization. So I often say that in our country, what we are lacking is the system. So if system is lacking, then improvement comes once there is a existing structure. I mean, you can't improve if for some issues system is not there. So I don't know when the newer AIIMS-like institution will start sharing the load of the patient in different part of the country so that one institution is not fed up with number of so many patients which it's difficult to handle. Now AIIMS has become now too big and is still expanding with a same ground space, which is impossible. If I have to go to OPD, just within the institute campus itself, there is a crossing for the vehicle within the campus. I'm not talking of a crossing outside the institute in near Aine Market or near Hojkaz. Even within the institute, there is a crossing. So where we are going, if it is there are 4 more blocks are coming in the institute. ठीक है, आप एक ब्लॉक में से नेफ्रोलॉजी में आप 200 बेड्स कर दोगे, but then where those 200 patient and 2 relative of each patient, which is usual culture in our country, so where that crowd will go actually? because ground space is same.
And in any case, sir,
And one of the things which in a West, which is somebody should think, in a Western setup, even a very small city, or in their terms they call it village, is reasonably full-fledged for medical care. हमारे यहाँ तो if you go out of metro city, a nearby city, you will find there is no nephrologist, and if you go to Hapur and further down, Muzaffarnagar, so for a large number of a little bit major diseases, and person has to rush to Delhi. So our healthcare delivery system is disproportionately established in terms of a metro and 2-tier city and 3-tier city, and that is also creating too much of a problem. Another concept which we should learn from the Western setup, in a Western setup, every hospital, say if you take Manchester in UK, every hospital in Manchester doesn't do kidney transplant. So I've distributed, so large number of facilities are distributed within Manchester to one hospital for liver transplant, another hospital for kidney transplant, another hospital for heart transplant.
And that is one city.
That is within one city. So not that every hospital is, you see, there is advantage.
And very much more sparsely populated than ours.
Much less sparsely populated.
Yeah. So I think, but those are very ideal situation. Dr. Agrawal, you have been in AIIMS for 35 years.
But Kamal, till what time we will continue to say that we are away from ideal?
That is
after all, you see, I will tell you, kidney disease till 2009, in a health ministry, there was no mention of a kidney disease as a part of non-communicable disease. So you can imagine, if there is no kidney disease as a part of non-communicable disease, prevention of kidney disease issue doesn't arise, because there is no, I wanted to do some prevention study. They said that there is no, kidney disease is not part of the non-communicable disease. So there is no NCD cannot fund because this doesn't exist.
So absolutely, there are many lacunas at every end, which at every level, which are, kind of making where we are today. Dr. Bajaj, the one aspects which we were discussing about, there's one, 2 points coming out from Dr. Agrawal's, views also. And one that, and since you are trying to provide, he mentioned about, our tier 2, tier 3 cities, Hapur, Muzaffarnagar and all that. And he mentioned about, you will not find even a single nephrologist in hospitals over there. The one area where you are trying to, fill that gap, how has been your experience on that? Because at the same time, what we are also seeing, that despite having relatively large institutions or hospitals at different part of our country, and especially in northern part, people have the tendency of going to certain cities for seeking healthcare. When the healthcare is provided at their doorstep, maybe players like you, when they are, kind of ensuring that, do people respond to the same way, or they still want to go to, Delhi or for different other cities from different other parts to seek healthcare? I'm seeing, the cities like Lucknow and Kanpur, they have good number of big hospitals. They still, people have the tendency of traveling to Delhi and for the treatment. This is one point, because this also, somewhere it's a question mark on both sides of patient centricity. The patient centricity of hospital over there, they are somehow not able to, instill that trust in the people, and it is also spoiling the patient centricity, or at least making it out of question itself in the large hospital in large cities. So how do you see this scenario?
So there are two parts to the question. One is, of course, whether we have enough doctors, and that is a very painful question, and we can discuss it at length. For 150 crore people in India, you have only less than 2600 nephrologists. So जितने शहर हैं उससे कम nephrologist हैं हमारे पास इंडिया में. So 2600 nephrologists we have. For 77 diabetics, we are producing only 67 endocrinologists every year all across India. So this production of doctors is an artificial constraint produced by people who benefit out of these constraints. वो कहते हैं ना, एक आपदा जब आती है तो अवसर उसी से मिलता है. तो आपदा है कि डॉक्टर कम है, उसमें अवसर किसका है वो हमें देखना चाहिए, किसके लिए है वो अवसर, और वो गवर्नमेंट क्यों क्रिएट करती है बार बार. Why is it that Dr. Sanjay Agarwal sir is seeing 100 patients being the professor? So I am sure his department is seeing 1,000 patients daily. Why are they producing only 3 DM candidates per year, or 4 maximum? For a similar load, the talk we do about Manchester, I think for a similar patient load, they will be producing at least 50 nephrologists every year if they have a similar patient load. Their patient load is less than 100th of ours. So why is it that we are so artificially constrained? Because if supply becomes higher, then who will pay money running to the tunes of crores of rupees to buy that seat? If we have 50 DM nephro seats in AIIMS, why will people pay 5 crore rupees and do it from a private medical college? And that artificial constraint will always be there because that private medical college is owned by our politicians only. So they need the government, AIIMS, etc. to be understaffed, and that is the precise reason why Dr. Sanjay Agarwal is perplexed that why are we not able to hire nephrologists even at premier institutions like AIIMS, because we are simply not producing enough. So that question, I think, is more of a political will. We have ample infrastructure to address that, ample patient load to address that, ample professors and teachers interested in academics to address that. It is just a matter of political will, which I think is weighed down by a lot of financial considerations more than anything else. The fact that patients want to travel to Delhi, I think, is an evolution in healthcare that we are seeing, and we have seen for the last 20 to 30 years, and it is a continuing evolution. So imagine that in the 80s, when we were in Delhi, 80s or early 90s, if you had a heart attack, you would do only one of two things. Either you travel to Chennai Apollo, or if you had enough money, you travel to the US. There was no treatment for a heart attack in even a city like Delhi. Everyone used to go out. And then, of course, Dr. Trehan came in with his revolutionary Escorts Hospital at that time, and then all the big corporate hospitals started coming in, and then Delhi became, instead of exporting medical tourism, it became one of the largest importers of medical tourism. And this is exactly what is happening in the small towns. So in small towns, if you have a heart attack, you have no choice but to hire a jeep and travel 3-4 hours to the nearest big city. Now we are getting in cath labs, etc., but the mindset remains the same. So if you have time, so in a heart attack you don't have time, so that is the first thing that the small town population migrates to, that okay, in an emergency at least we should go to the Ujala Cygnus Hospital because it has all the emergency facilities, it has a cardiologist, it has a cath lab, everything is there. But in elective procedures like say for fertility or nephrology or joint replacements, the behavior will take longer to change, because trust builds up very slowly in healthcare, and it is all word of mouth. But it's not like that it's not building up, it is. So in a small town like Kethal, which I think most of the panelists wouldn't even have heard about, we are doing more than 50 knee joint replacements every month. It was unheard of 4 years ago that we could do a joint replacement in that town, but now we are doing 50 every month. So people migrate very quickly to something that gives them comfort, something they have trust in, something that saves them money, provided you communicate it clearly and your product matches what you are marketing, right? It's not like you communicate and then when they come, your joint replacement program is a shoddy program and you are not giving good results. So you have to give good results. That is a hygiene. But your communication and ability to get the trust flowing into the patients is something that will take some effort, but it is happening as we speak. uh, there will be a transformative change very quickly as urbanization picks up. Hey, Rags.
Thank you so much, Dr. Bajaj. Yes, there are certain you have highlighted as an artificial constraint created, which is kind of leading to the consequences of not having that not robust, not even a base level of or a minimum level of patient centricity we see lacking in many aspects. A quick question to all three of you, because after that we will be closing this session and the next session panelists have already started joining in. So we talked about the cost which patient centricity can take. Dr. Pai has very kind of strongly put it forward. So let me start with Dr. Pai only. Dr. Pai, what is the how much are insurance and maybe government schemes covering the aspects which are related to patient centricity? Because patient centricity requires a lot of other aspects also, where the insurance many times may not be effectively providing a coverage. Dr. Pai, you there?
Yeah, what is the question? Can you come again?
Yeah, I'm saying that patient centricity, you mentioned, requires a certain kind of higher expenses. It is a cost which is more than the usual cost which we see. Now, do our insurances cover this kind of aspect, which to ensure that you have a better patient centricity, better participation, you have a better support system for patients? You may have to kind of patient centricity also requires better follow-ups with the patients. You may have to kind of provide some kind of, you talked about technology and AI. You need to create some kind of support system for patients so that they can have a better connect with the similar kind of patients and get certain kind of thought exchange and support system around them. They may also need certain kind of a chronic disease management. They may require a certain kind of follow-up processes. So there are multiple aspects related to it. Does our insurance cover all that, or even the government insurances like Ayushman Bharat? What is your opinion on it or experience?
So no, the insurances don't cover. I don't think they cover. But as the more and more insurance penetration is there, with the turnover, it will get automatically covered. So I think one of the yesterday that was in the panel, Dr. Sanjay Oak, who was our director of the COVID task force in Maharashtra, made a fantastic point. What he said was that now we need more vertical insurance, not horizontal. Of course, we need a penetration horizontally, but the costs of covering have gone up. So I think that more premiums when you pay, then you get more, you can have more flexibility in giving better care. So vertical penetration of insurance is equally important as the horizontal penetration, because obviously with lot of care will come lot of expenditure. Look at this ART bill. So many, if you look at the criteria, you have to put more people, more employment has to be done of people.
Connection has some problem, Dr. Pai. Dr. Pai, okay. Okay, let me go to Dr. Bajaj and then Dr. Agrawal and close this. Dr. Bajaj, you have been contributing.
I can't. 1 minute.
Yes, sir. You are back, Dr. Pai. Okay, I think yes. So Dr. Bajaj, Dr. Pai is talking about that we need more of a vertical kind of insurance coverage. Horizontal is also, I need to understand it better. But most importantly, you and your hospitals are very, extensively working with schemes like Ayushman Bharat. There is a certain coverage involved, certain diseases involved, certain diseases are not involved. Dr. Agrawal has also very rightly mentioned that, even kidney disease was not under, in the NCDs, and is still in Ayushman Bharat. Many of those aspects are lacking because I think there is a systemic, thought process which is not making them be very comprehensive in the coverage of diseases and then, the associated factors. How do you see that in, these kind of schemes? Does these schemes really value something called patient centricity?
So, although on a principle level, I am vociferously against insurance and fee for service, and as I've expressed many, many times, the incentives of the doctors and the patient is completely misaligned in an insurance based model like the US and India. But still, I feel that the schemes like Ayushman Bharat do bring to the fore patient centricity, if not directly, then definitely indirectly. Because see, what happens in Ayushman Bharat is, say for example, you're doing a lap cholecystectomy. So a cholecystectomy rate is fixed that you will get 16,000 rupees whatever happens. So if you botch up the surgery, if you have any complications, if the patient needs an extended stay, if the patient gets readmitted, or if the patient goes back to the OT, it's only you who's bearing the cost. There is no one else to bear that cost. So the surgeons and the hospitals are very cautious that there should be no complications. Try and make the surgery daycare if possible. Get the patient home as quickly as possible. Give a single shot of antibiotic. Save on incisions. Do a very minimal invasive surgery so that the patient is back to work as quickly as possible. So indirectly it is a patient centric initiative because you are doing your best to make sure that the patient gets home as quickly as possible, because it is a financial incentive for you. So indirectly patient centricity is definitely borne out by schemes like this, but of course, to really make sure that patient centricity is at the center, really truly the center of everything we do, we need to redefine the healthcare delivery model completely, in my opinion.
And maybe then this very, predefined, concise package model may not incorporate all that which is needed to support a patient or to really be empathetic about the patient. Yeah. So Dr. Agrawal, a quick comment from you. Anything you would like to add about schemes like Ayushman Bharat or any other government funded scheme or the insurance, and does that cover or value patient centricity?
No, I will only say 2 points. Number one, Ayushman Bharat is a very good scheme because many patients who otherwise couldn't afford the costly treatment are able to do. But one of the major things which many may not know, that Ayushman Bharat only covers the population who is below poverty line. And we should understand that a huge percentage of population is not below poverty line, but also not sound enough financially to afford the treatment. And
they will be gradually, increasing the coverage, sir. I think they have started understanding the middle, missing middle. Also,
missing middle is a huge chunk. It is more than the below poverty line and more than the people who can afford.
The government has already announced that they are going to cover by 15th of August the 40 crore missing middle. They will cover by 15th of August. But sir, the question is a deeper question, more fundamental. Even if they do cover, they will cover your dialysis. They will do dialysis. What happens before that? Why are they not preventing kidney failure? Is the patient centricity that does not cover that? And that's
I can tell you why. Politicians need a result of their scheme of immediate, and prevention will give the effect after 10 years, 15, 20 years. So they know that not
need, how it makes an important contribution towards back practicing in our healthcare system. There are a movement towards that. There are the system is kind of getting awakened to more patient centricity. The professional, the patients, all patients group, supports group, all are together working towards it, moving towards it. But I think it's still a long way to go and requires a lot of systemic changes and modifications as all our experts highlighted today. So with this, we hand over the next session to my colleague Behjat Moini. She will be discussing with another set of experts how patient centricity can help us achieve better health outcome in our country. So thank you so much, all our experts, panelists today. Really value your time and appreciate your participation in this. Bye for now.
Thank you. Bye.
Thank you very much.
Thank you.
Behjat, over to you, please. You're on mute.
Yes, thank you, Kamal. So it was a very enlightening session. Moving on to the next topic, which is impact of innovation, digital and new technology in patient services. So I would take this opportunity first to introduce myself. I'm Dr. Behjat Moini, a doctorate in cultural anthropology, and I have almost a decade's experience in content, research, and of course, development communication. So my foray into the development sector was basically of the passion that I feel, with important issues, environmental issues, health issues, and of course, issues of persons with disability. So without wasting any much of the time, I would just, start the session. Now, while it is true that the pandemic has changed the world in unprecedented ways, and it has, revamped everything involved, the health sector is one sector which has, which the status quo has been challenged in the most, in a very extreme manner, if I can say that. So the new changes that the pandemic has ushered, how we have gone back to the virtual mode of everything from learning to interviews and everything. So a new world has been created in that sense. So in keeping with that, background, we would just start with the session, and let me take this opportunity to introduce our experts today. So we have with us Mr. Raghavendra Prasad, founder, Step One, a non-profit volunteer organization helping India fight COVID by providing free telemedicine access to COVID-affected citizens in India. He's an active angel investor and advisor for many startups. His primary interests are in technology and business models which can help rural India better integrate with the rest of the India as well as global economies. He has over 20 years of experience in the software industry. He loves solving people's problems while using technology and has spent most of his career doing that. He has a keen eye for spotting trends and new innovations to solve problems and has launched over a dozen global products with over a dozen international patents to his name. Welcome, sir. Then we have Mr. Kunal Kishore Dhawan. He is the CEO of Navya Life Care, a healthcare startup based in Delhi. He's a former strategy and business development professional at Fresenius Kabi, a global pharmaceutical company, and with prior stints at PwC, JSK, Abbott Vascular, and US-based VC firms, Pittsburgh Life Sciences Greenhouse. Kunal is a master's from Carnegie University and is responsible for strategy, business development, and operation of the company, along with providing the medical perspective to the venture. So without wasting any more of the time, Raghavendra, coming to you. since step one has, worked on ground during the COVID pandemic. So would you like to share with us some, experiences, how technology because COVID was a situation where physical proximity was a complete no-no. So please, share with us the experiences that how technological interventions at that point of time became a life-saving, concept.
Sure. Thanks, Bijit, and greetings to Kunal, and good afternoon to all the participants. I think, the last, I would say 20, 30 years technology has been improving and taking over our lives. So I consider what happened during the pandemic only an accelerator for technology, because the technology integration of technology into our daily lives, you can say that has already happened in some areas. I think the healthcare has been one of the areas which was lacking largely before the pandemic, but the pandemic basically accelerated adoption, mainly by multiple constituents. I think the key things that happened during the pandemic was, I think, for over a decade, telemedicine guidelines were being discussed, and it never came out. But as soon as the pandemic started, the central government released the guidelines, and it was mostly unchanged, accepted and adopted by most state governments, because health is a state subject. So we saw government themselves moving fast. If you remember, I think the government was the first to launch Arogya Setu. In fact, it became the most downloaded app in India for a short while. And if you look at ICMR, which kind of assumed the leadership, every test that got done for COVID, was centrally linked to the ICMR portal, so that the distribution, there was a centralized monitoring of the cases and distribution of the same to the people who are fighting. Largely, the state governments, if you look at the states which actually did well, in terms of reduced, they were successful in reducing the mortality and morbidity and the spread of the virus. They used a lot of technology in actually managing and coordinating the response to the pandemic. I think for the people themselves, right, got more adopted to technology, because that was the only way that they could connect to the outside world, right? I think Zoom became a part of our lives during the pandemic, right? And also, the most of the shopping had to be done online, whether it was WhatsApp or through one of the apps. And also technology played a very important role in the way patients or people connected with their healthcare providers, be it doctors, be it counselors, be it nutritionists. Because there was no physical contact possible, it forced most of them to rethink or to use technology. And actually, even now, you will see the remnants of that. Most people are using technology as the primary means of finding out about what they should do for their problem, as well as reaching out to their doctors. So I think technology has had a irreversible path, has created an irreversible path in the way we will access healthcare going forward. Every house today has a pulse oximeter. They have digital thermometers. Many of these devices are connected to apps. So, we saw a proliferation of technology-enabled devices into people's homes like never before. And that's a trend which is also going to continue. I think that we're going to see people know that just by getting that measurement, they know whether they are in a safe zone or they are in a zone where they have to worry. So, very simple devices can actually end up saving lives is what people have realized, right? Which are, these devices are not, of course, they were quite expensive during the peak of the pandemic, but these are available for, these are what I would call as inexpensive devices for the advantages they give. So in many, many ways, technology has infiltrated our lives, and specifically the way that we think of healthcare and we think of access to healthcare, and that's a trend that's going to be there for the future.
Right. Since you've talked about how the trend is going to, continue, that was my next query, and I would ask Mr. Kunal Kishore Dhawan to, since we shifted to that a model of virtual thing. So it was at that time it was a necessity. It was a compulsion. But now we see it, it is like, do you think it's the preferred model? So do you think it's going to, in the coming time, in the times to come, it is going to stay there, or are we going to get back to the previous model? What are your thoughts on that?
Yeah, first of all, thanks so much for having me on the panel. I really appreciate it. Hi, Raghvendra, pleasure to meet you. I've been wanting to have a chance to speak with you, but glad we got to connect through this. So great question. I think, Raghvendra put it very, very excellently there, that the natural progression of technology was sort of accelerated due to the COVID pandemic, but it formed a sort of a, inherent behavior change. It led to an inherent behavior change amongst almost all stakeholders. One of the key stakeholders that was sort of lacking for the longest time were the doctors. That we felt that the doctors were the most hesitant in adopting technology for various reasons. But over the last couple of years, what we've seen is that a lot of doctors have themselves tried to adopt all sorts of support systems that are technology driven, whether it be simply conducting teleconsultations through step one via WhatsApp or something like that, or even being part of larger service providers who are giving this service. There has also been an increased adoption of things like electronic medical records. There has been increased adoption of total devices, as Raghvendra also pointed out. So there has been a clear shift in the mentality of the key decision maker in the ecosystem, which is the doctor. What we are seeing also in the recent few months, once the third wave sort of waned off, and now it's pretty much we're starting to live with COVID actually, rather than trying to beat it anymore. What we've seen is that doctors are, and patients of course, are kind of preferring a very hybrid model. They are finding ways in which they can go back to sort of a new normal, where they are utilizing technology in cases where they can. So in certain specializations where physical touch, etc., is not required, there has been an increased adoption of technology, and it continues to do so. We have seen, specialties like psychiatry, specialties, even general physicians, diabetology, where there is regular follow-ups, are all being done online, or a large chunk of it is done online. But we are still seeing that there are some specializations that prefer that physical approach. So patients are going back to the clinic, in cases like dermatology, dentistry, where there is no option, that you cannot do much of work on a digital scale. We are seeing doctors go back to their physical thing. So what I assume, and what we are also kind of working on at Navya as well, is that there will be sort of a hybrid approach. Out of the 4 billion odd consultations that are done every year, about 3 to 5 to maybe about 10% or are going to be completely virtual, whereas the rest of them will continue to be physical.
Okay. So since Mr. Kunal Kishore, he specifically talked about the inherent attitude change. Since we Indians are, and I myself, a bit, wary of technology. We don't trust technology as such. So, and it was a surprising bit of information that doctors were the, most, I never thought that they would be. I thought it's more like, because we have a very rural, kind of setup also. So I was thinking that maybe the gap would be in those areas, but that was a new information. So Raghvendra, what do you think, like, if we talk about this inherent attitude change, what, according to you, like, what are the chunks that we need to focus on when it comes to, because there are, okay, the virtual world is good and everything is moving on in spite of COVID, but then there are technological hassles. There is a large chunk of population which is not very, technologically advanced per se. Then we have persons with disabilities, a visually impaired person who cannot access, written information, things like that. So what is your take on that?
Sure. So I'll focus on both the stakeholders, the doctors and the citizens or the patients. I think as Kunal rightly said, right, the biggest pushback to adoption of technology was from doctors, and that was due to various reasons. But one of the key reasons was, how do I get paid, right? I think India has, over the last few years, come of age when it comes to digital payments. I think we are leading the world right now when it comes to digital payment. So so this trend of digital payments has actually helped doctors feel confident about getting paid, because in the past, if this pandemic had happened, say, before the UPI and the digital payments really took off, we probably wouldn't have seen the same kind of proliferation of adoption. But now I think that trend has really helped. Another thing which has driven this change is the fact that patients or citizens in general, right? We access everything online, and there is kind of become like a preference for doing things online because it's just more convenient, right? You can do everything that you can basically do everything that matters in your life online these days, right? You can and if there is an offline component, you can get that home by placing an order online, and that's a huge convenience, right? And that convenience is really what has led even the consumers to prefer that for healthcare as well. And that trend is not going to change, right? It's only going to, more and more things are coming online, and doctors or healthcare providers who are going to resist online are going to be left behind, and the newer ones who are more proactively embracing online technologies are going to succeed. So that's a irreversible trend that we are seeing in the world. When it comes to the citizens, there is definitely a digital divide, but that is fast closing. That gap there is fast closing. In fact, for step one, this was one of the key design criteria for when we were designing. How do we get the person in a village who has no access to a smartphone, no access to data, how can we still serve them? And we largely used telephone, just the normal phone call, so people could just access a doctor by just making a phone call, which I believe to a large extent is universally available. Of course, there are still areas where a telephone connection is hard or not reliable, but that's fast changing, right? And with the proliferation of smart devices and data, 4G and now 5G is going to come. This hopefully in the next few years will also not be a criteria or consideration. And one of the things that we have seen is that most people, while they even the rural people are very capable of using smartphones, specifically WhatsApp. In fact, the next ubiquitous thing to a phone call is WhatsApp. So a lot of our services we actually made available on WhatsApp. And WhatsApp is a very media-rich medium, in the sense you can send videos, you can send graphics. So there is so much that you can do. And today, most people who can use a phone are also capable of using WhatsApp. Right. So, there are such mediums that are evolving, and I'm sure in the future there will be more such apps and more such services that are available, which will actually bridge the digital divide a lot more. And it will make it easier and now WhatsApp is also natively handling payments, right? They made it so easy to pay, a user, another WhatsApp user, because payments are integrated within WhatsApp. So it just makes it much easier for using, for users to adopt and bridge the digital divide. And what we've also seen is in most homes and villages, even in villages, most homes or most communities, there is always one person who is capable of, using the apps, and who's a little bit more savvy. And most people default to them, either if they want to buy something on Flipkart or Amazon, or
right.
the people find a way. But it's also very aspirational for people to learn how to use an app. It's very aspirational for people to use WhatsApp and the smartphone fully. So people will actually learn these things, and I think the digital divide will be a thing of the past very soon.
Right. So since you've talked about that, the trend is going to stay there. Even Kunal said that it will switch to a hybrid model, but it will be very much there. So how, since you have worked on field, I would want to know how can we, make sure that, because when we talk about health, WhatsApp and ordering stuff, and I've seen, even villages now order stuff on, they deliver stuff, Amazon and Flipkart all. But when we talk about health specifically, so, you cannot leave a single person behind, as we saw with COVID. If one person in a community is not getting vaccinated, he might be a threat to the whole, family. So how do you make sure that, with this new hybrid, technologically advanced model, we include everyone? Inclusivity and accessibility are two important issues that, I would like to know how Kunal, please let us know, how do we ensure that?
Yeah, I think the first is something which is already happening, right? Like there is already internet being spread across the country to a vast majority of the population. I think we are already 1 billion plus people who have access to phones, about 700 plus million people plus who have access to smartphones, and the number of and obviously when they have smartphone, they also have internet access, and this number is only increasing. The cheaper the phones, the more accessible they become, the more affordable they become, and then obviously more and more people will go and morph themselves into a phone user population. That is a very interesting thing that has happened, that we have completely skipped the whole laptop side completely. So we've moved, some people had access to computers, and then suddenly everybody has access to phones. So with the middle ground of having a laptop or a computer to a large variety is completely skipped in India. So from a point of view of inclusivity, it's all about putting access to information and access to technology in everyone's hands, which is one happening naturally, like I mentioned, and the other one is happening through the availability of healthcare services on digital modes. So even today, less than, like I said, 4 billion consultations, only about a percentage of them probably happening online. A very, very few percentage of doctors use technology in their daily practice. So as more and more doctors get included into the digital sphere, with the ABDM coming in, the Ayushman Bharat Digital Mission, National Digital Health Mission, or the National Health Stack, it is creating that framework where a lot of participants, including doctors, patients, the fulfillers, prescription fulfillers, pharmaceutical companies, insurance companies, everybody will be on a single framework where the access to information or movement of information will be seamless, and which will be sort of a key driver in patients adopting technology. So as the other stakeholders start using technology more and more, the patients will be more comfortable in having their records digitized, having their being part of the national health stack, creating those Aadhaar IDs, etc. So it'll partly regulatory and partly by the availability of this kind of a technological revolution that we are seeing in the ecosystem, in the health ecosystem, the inclusion will gradually follow suit.
Right.
So if I may add to what Kunal said, we have close to 6.6 lakh villages in the country, and we have roughly about 90,000 PHCs. So we don't have only 1 in 7 villages potentially has a PHC. So we have left out 6 villages with no access to even a medical worker, which is what is present in most PHCs, right? Most PHCs don't even have a fully qualified doctor. So I would actually argue that the only way we're going to cover the rest, which is a mammoth number, right? We are talking about close to 5.8 lakh villages, right? We don't even have that many doctors. The only way we are going to cover them is by using technology. So without technology, universal healthcare is not going to happen in our country at all. It's not possible for us to establish so many PHCs and provide a doctor at each and every village. It's just not going to happen. Certainly not in our lifetimes. But what is easily can be done within our lifetimes is provide them easy access via technology to a doctor who may not be physically present in their village, but somewhere close by.
Right. So since you've talked about how, it has to be a very patient-centric kind of an approach that we have to take. But when it comes to like many patients have, they don't consider actually this online mode of consultations and things as a very reliable means. And doctors might be also of the opinion that this virtual kind of thing might sometimes compromise on the quality of service being provided. And secondly, there are certain examples, if we talk about surgical procedures and of course, counseling and all, where person-to-person contact is inevitable. So what would you like? How can we ensure that, do you think that somewhere down the line, it's true that virtual consultations, are not at par with what a doctor will, if he will physically examine you, and how do you, what are your comments on that kind of a situation?
So I think the question is not, should never be virtual versus, real world. It should never be that. I think that's probably a wrong question. The question should be, what can I do to make sure that the person knows what is the right next step for them, right? Okay. Which could be, and can we do that in the most friendly manner for them? And which, and the right next step could be to visit a hospital for the care. I think one of the things which I see happening is, there's going to be a lot more medical devices which are going to give various signals about the human body. There's a proliferation of them, which will actually make it possible for a remote nurse to take vital readings, which will make the job of the doctor much easier. In fact, that is already happening in eye care, for example, right? A lot of eye surgeries today are being detected, or eye issues are being detected by a team of people who are not doctors, but they are enabled by a device which is taking very high resolution pictures of the eyes, and using a combination of technology and doctors, they are determining what kind of a problem that this person has. And all of this is happening in a non-real-time basis, but the end result is the person who cannot afford to take a day's leave to travel 200 kilometers, or is actually getting to know that, hey, he's due for a surgery, or he needs this kind of treatment, which could potentially be provided him without leaving the village. So I guess we need to empathize with the people while designing these systems, right? Most people in the rural area are in formal jobs, and they only earn when they work, right? Manual labor or daily wages is very prevalent, and there is no way that these people will have an incentive to drop their work and go to a hospital without knowing what to expect. But if they're well prepared that this is what to expect by a consultation that can be done remotely, that is actually a lot of progress and a lot more convenient for them. So
Kunal, would you want to add something to what Raghavendra has talked about, how we can ensure the right mix of both the technologies to make it more patient-centric in a way?
Yeah. As Raghavendra rightly mentioned, it is not about this versus that. It is not about physical versus virtual. It's about complementarity, right? Where does what fit? Like in a typical follow-up process, where is a physical intervention required? Whereas where can a virtual intervention be enough for taking out? I mean, because that is important from a cost perspective also. We have seen that overall, from a affordability perspective, a virtual consultation is miles better than a physical consultation. It reduces the amount of effort, travel time, etc. Everyone is benefited from having a virtual consult.
Right.
So it will be important for also a lot of education about the benefits of a virtual consult.
Right.
That will go a long way in alleviating fears that a patient might have. Today, what we are seeing is that if anybody feels anything, the moment they feel anything, especially in the areas where there is availability of healthcare resources, they just rush to the clinic. Is it even required? Can there be educational material? Can there be educational, content, etc., that is available to the patient or to prospective patients who are currently in the process of a treatment, etc., that they could leverage. Additionally, if doctors themselves start pushing on adoption of digital, then it will trickle down to the patients as well. So it is not just the patients who are kind of wanting these, who are going to be going for the services, but also a little bit push from the doctor's side will also go a long way in ensuring that patients start accepting it. And the moment patients start again, it's a positive feedback loop. That's what we've noticed. That the moment doctors push it, then the patients adopt it, and when patients adopt it, automatically more and more doctors will start pushing it. So we are going to be seeing that. And there will be an automatic balance that will be struck, where people will be aware when they need physical intervention and when they will need technological intervention.
Right. And a lot of awareness around those things needs to be created in the right manner. Right. Anything else that Raghavendra would want to add to that?
Yeah, I think it's a very exciting time to be in the healthcare space, specifically in the public health space, because I think in the personal health space, technology adoption was always happening, right? You see the Apollos and the Fortises and all the major hospitals promoting telemedicine big time, even before the pandemic, right? They had options and use of technology in terms of very advanced technology was happening, but public health was largely left behind, right? I think the central government launching the eSanjeevani, which is a free telemedicine, is a great first step. The use of I think the PMJ scheme is largely using digital means to process the PMJ insurance claims. So the adoption of technology, which is happening in public health, and it's happening at such a rapid pace, is something really, really heartening to see. I don't think we ever had this level of technology penetration in public health like what this government is driving, and this is giving boost for organizations like Project Step One, which is inherently technology-led intervention, and it's just giving us a lot of boost to work along with the government and push the boundaries of adoption of technology much further.
So what we can see that like the pandemic has acted as a catalyst for revamping of various trends and in healthcare, including shifting consumer preferences, rapidly evolving technologies, and clinical innovations. What is needed, what is the need of the hour, is to ensure that we have the right balance of both, and to ensure that inclusivity, awareness around health, and and everyone is included. So that was a very enlightening session, and on behalf of IHW Council, I would like to thank Kunal and Raghvendra both for their time, and thank you.
Thank you. Thanks so much.
Thank you, Bejat. Very well conducted session. I really enjoyed being here.
Thank you. So over to Anisha Nair Dhawan. Dhawan, she will be moderating the next session. Over to you, Anisha. Over to you.
Thank you so much, Bejat, for this discussion. Indeed, happy customers, happy and satisfied patients are definitely on the faster road to recovery. Now, medicine is an ancient science and has been practiced over thousands of years in our civilization. Doctors are treated nearly as gods on earth by patients, especially in some of the rural areas where many a times doctors and patients develop a personal bond. Now, India has underinvested in health for decades now, and this shows in the unreasonably high patient load doctors at public hospitals have received. Not being able to spend enough time to emotionally connect with their patients is one of the biggest casualties of public healthcare. On the other hand, large corporate hospitals are seen to depend on large volumes to meet high overheads, and the doctors in these private hospitals are sometimes viewed suspiciously as unscrupulous for recommending numerous tests and expensive follow-ups. Now, how do we build a patient-doctor relationship which is based on trust and transparency? Are hospitals investing in patient management as they improve the infrastructure? Are patients' interests front, right, and center for those in India's healthcare sector? In this session, we will analyze the impact of patient advocacy in modern healthcare delivery mechanism. And it gives me immense pleasure to introduce to you the eminent panelists for this session. So please join me in welcoming our panelists who have joined us and many who will be joining us as well. Please welcome Dr. D.S. Ratna Devi, founder, India Alliance of Patients Group. Please welcome Mr. Vivek Thomat, patient advocate. Dr. Sukriti Chauhan, founder, ETI Services and INLAX scholar. Ms. Poonam Bakai, chairperson of CanKids, and Ms. Arshia Bhandari, founder of PHP Fit. A warm welcome to all of you. Thank you so much for joining us today. For some reason, I'm unable to see my screen. Yes, now I see everybody. Thank you all for joining us. It's a pleasure to have all of you with us on this panel discussion where we're talking about a very important issue. I want to start with you, Arshia. Do you think patient advocacy has a role to play for hospital companies, drug companies, and diagnostic companies? Or is this just something that patients have to deal with or bother about?
Hi, Anisha. Hello, everyone. Thank you for inviting me for this event and for being part of this discussion. Yeah, so to your question, of course, patient advocacy is very, very important and it has been seen since 1950s. It has played a very important role towards, it is very significant. It plays a very significant role towards helping patients understand their rights and collaboration between the government agencies. There's through patient advocacy groups there with their collaboration with the pharma companies. There's so not just they are able to understand what are the important what is important for the patient. So if we take the example of rare diseases, it is important the patient advocacy groups that are there are able to talk with the pharma companies, collaborate with the pharma companies to advocate for the patients with rare diseases and those the drugs for those or research for those rare diseases can be done. And it's the same with the patient advocacy groups that they can collaborate with. The government agencies, they have a very important role to play with policy making and policy change. So I would like to talk about the National Patient Safety Implementation Framework. And there's a very important statement that is there in the framework that says that there needs to be a demand from the population for policy change in healthcare for patient safety. And that's a very important statement because this is what patient advocacy groups can help raise demand with discussion with the patients, with the healthcare associations and with the hospitals, that what is it that patient needs and how this can be achieved in collaboration with all the stakeholders. So I think this is where the patient advocacy groups can really, really help, and they're very important in this role. Thank you.
Right. Arsha, you highlighted the case of rare diseases where a patient advocacy is very important. But Dr. Sukriti, I'm still trying to understand that a demand should come from the patient side that this is what is required. Otherwise, would that not occur to pharma companies, hospitals, and diagnostic companies? That should there be a demand? I mean, is this attitude right that we do provide for them, we give them what they need? Then what is this thing about patient centricity? We solve their problems. What more do we do? Is it really required?
Thanks, Anisha, for having me. Are you talking to Arshia or
yes,
are you talking to me? Sorry.
Dr. Sukriti, please go ahead.
Okay. Hi, Arshia. You want to just start? I can just pitch in after you. I'd love to hear what you have to say on that.
So that's okay. I think you can go ahead. I'll pitch on that.
All right, thank you. Thanks for having me and honored to be here. I think, let me be very blunt, Anisha. At the beginning, let me just put out what I frankly think. Pharma industry just overall very rarely has looked at situations from patient rights or patient frameworks, and that's the reality. It is a business, a very important business, because drugs and innovations need to reach people. But I do think there is definite space in talking about really looking at perspectives of the people who are at the end struggling with the diseases. I think the human approach has been missing. I think there's been development. There are patient advocacy groups which have been set up by agencies like GSK. We've got some very good examples in India. But I just want to take everybody a step back. You asked, why is it that people need to demand? Everybody wants situations to change, and that's where we need to demand for that change. And patient rights in this very complicated medical access system is something that's ignored. And I'm so happy to be on the panel to reiterate that, we have some very good examples, example HIV, the journey that people really went on together as a community that was impacted, and the way that they were able to demand for that change is what really saved millions of lives, as we know. So, we have multiple examples like that, but I do think patient advocacy groups are absolutely critical. There is absolute truth in the fact that patients need to demand for that change. I wish it was otherwise, but it isn't. And that's the truth of the situation. Sometimes money trumps where rights stand in the way. And I'm sorry for being blunt, but I wanted to open the discussion with a very harsh reality.
Right. Datta ma'am, do you concur with Dr. Smriti? Because, at one point, hospitals, drug companies, diagnostic companies, they're there to serve patients. So how is it that their interests are being ignored, or their interests are not centric to what these companies are doing? So many times we hear, oh, it's just a business for them. Aap kya ho? Aap to sirf business ka zariya ho. But if you don't treat them, if you don't give them what they need, how will your business flourish?
Anisha, are you speaking to me?
Yes, ma'am. Please go ahead.
Oh, thank you. Your voice is breaking in between, so it's a bit hard to understand. So thank you for that, and thank you for inviting me to this panel. And I'll just quickly answer the first part of your question as to why are patient groups important, and then I will address what Sukriti has just said. So, if you look at a patient and whichever disease area they are suffering from, there is a journey in that. So there is a journey where they learn what they're suffering from, they ask questions, then they go to somebody who is able to help them diagnose and arrive at some kind of a conclusion of what their disease is. And then they start looking for treatments where maybe a physician or somebody gives them the treatment. And depending upon whether the treatment works for them, does not work for them, they move in and out of the health system. And at all of these places, the bottom line, there are two things that they look for. One is, of course, they should be cured and happy or pain-free. And the second is they should be able to afford the treatment. So in terms of stakeholders, whether it is hospitals, drug companies, policymakers, etc., everybody has a role to play, and every person understands the patient in a different way. So if it's a drug company, they have a different perspective. The diagnostics have a different perspective. The hospitals have a different perspective. And the policymakers or the ones who are reimbursing the cost of therapy have a different perspective. And the central point to all of this is the patient. And unfortunately, all of these stakeholders never speak to each other. So so patient advocacy groups are the one who usually bring all these stakeholders to one platform and try and explain to them why it is important that all of them work together. And unless all of these stakeholders work together, you will never arrive at a solution that will make the patient happy. And to give you a very simple example, you can have a very good medicine for, say, hypertension that brings your, blood pressure low, but gives you a terrible migraine and makes the person so disabled that they are not able to work. So, in terms of clinical outcomes, the doctors are happy because the blood pressure is maintained. In terms of clinical outcomes, the drug companies are happy because, your clinical data shows that you have an excellent outcome, but then are the patients happy? And maybe it costs very less, so the policymaker is also happy. But are the patients happy? Do they get that medicine to just get a clinical outcome, or is it to give them a better quality of life? And when this whole issue of quality of life comes into picture, then patient advocacy groups are extremely important because they bring the lived experience to the table. They tell them what is working and what is not working. And if what is working for them may not be strictly within the ambit of clinical outcomes. And me being a doctor and also a patient advocate, I see both sides of the table. So I'm very happy when I see good clinical outcomes, but my patient may not be very happy with me because it's not making whatever is making that person sick go away. So that is why patient advocacy groups are extremely important. Now, to just address what Sukriti said, I have a slight difference of opinion. Yes, there is a commerce angle to it, but not only the pharmaceutical companies or the diagnostics companies and policymakers have come to terms with the fact that patient groups have a very strong role to play in decision making and in policy changing, but it is also the World Health Organization and other UN agencies that are increasingly recognizing this and holding informal discussions with people with lived experience to come up with charters that actually go to member states and help them understand whether their policies are in sync with what the lived experience is demanding. So world over, there is a recognition that patient advocacy groups have an extremely important role, and that is being more and more sort of integrated into policy making in most of the countries, whether it is LMICs, MICs, or developed countries. And I'll stop there.
All right. Vivek, let me come to you. Now, there is a lot to discuss on, what is patient centricity? Are people doing it? Are those in the healthcare system doing enough? Are patients happy with outcomes? But I want to try and understand from you, why is patient centricity now important? Is it because we live in an information age? Is it because service providers, be it hospitals or drug companies or diagnostic companies, have suddenly realized that, patients' views, their feelings, their journeys are important. Let's focus on that and not just the end treatment. Why is this happening?
So your voice was breaking, but I hope I understand your question. So first of all, thank you so much for this session, being part of this esteemed group. But more importantly, we are talking about patient advocacy. We are putting patients first, and that's very, very for the time of the need in India. So let me start with the thing is, we have to understand that when it comes to the patient advocacy, we in India are still far, far behind. We have to understand the difference that we have some great patient support groups, emotional support, financial support, so many organizations, they are important. Okay, and really respect them. But what is patient advocacy and why it is important, why it is happening, is patient advocacy is what is to what should be. And I agree, there is communication gap and there is so many gap, but the gap is, I think, the understanding also. So I was recently in a meeting for Ministry of Health, DCGI and others, and there were industry people, there were doctors, and there were a couple of patient advocates, and we got the opportunity, and everyone was talking like it is a commercial discussion, and it was very right. So companies were talking about them, ministry was talking about policy, but one thing was missing is the human component. And when we start to speak with our practical experience, what we patient, because we are the expert, doctors may be expert in the treatment, the government may be expert in the policy making, but we are the people who are living with the disease, we are facing the problems. So then everything become humanized. Then we were talking that what we are talking right now, at that time it was about cancer patient and how we can ensure research in India about cancer patient. Everything changed, and within 1 hour after that discussion, there were 5 policy changes came out. So policy changing is, we always underestimate about the patient advocacy. Patient advocacy is not giving crutches to who can't walk because of hunger. Patient advocacy is to give them food and strength so that they don't need patient advocate. They don't need others. They can walk, they can run. So that's need to understand, and that needs to change. And to precisely to your answer the question, this is the thing where is everyone is thinking about not understanding each other. And then I agree with Dr. Ratna, and patient advocacy brings all together, and we have to change that.
All right, bringing everybody together will help remove some of these obstacles in understanding. Poonam ma'am, you're a cancer survivor and you're a patient advocate. Now, I'm sure through your journey, you would have seen many changes. So my question to you is, does patient advocacy or have these groups made a difference to the care that is being provided to them? Maybe not 5-10 years ago, maybe not 30 years ago, but now.
Can you hear me?
Yes, ma'am. Please go ahead.
Yes. All right. So first off, what I'd like to talk about is, when we talk about patient advocacy, we're really talking about patient rights, and we're talking about the right to health. We've had some discussion around demand, right? So the demand is for my right to health. And are we addressing that right to health? That, I think, is the crux of the matter today, that when we say patient advocacy in healthcare, we want to really look and focus on what are the rights of the patients, right? And within that, then, who is demanding this? So I do want to bring this particular point up because we mentioned, a couple of the people have mentioned this, and the question is, who's demanding? If I'm going to treat the doctor as God, I'm not demanding. If I don't have the ability to reach the healthcare institution or administration, what do I end up doing? If I'm really angry, I beat up the doctor, right? And we've had instances of that. We've heard in the public space, somebody was really angry about, not being cared for adequately, or their patient not being cared for adequately. So if you don't have a channel whereby you can address the hospital administration, the odd patient will get mad and beat up somebody. But most people will quietly go home and complain at home. So where is the channel that we have created to communicate this in terms of the rights? So educating people about their patient rights and saying you have a right to health is very, very important. This is something that patient advocacy groups set out to do. I think that's important. Building up the patient voice so that the patient knows where and how to talk about what their issue is. Be it to the policymaker, be it to pharma, be it to media, or be it to a hospital institution, or be it because it's my health that is being taken care of, or my child's health being taken care of. So I think the discussion is in two parts. One is from the demand side, what can a patient advocacy group do? And you asked me the question about patient advocacy group. That's one role a patient advocacy group should have, to build up the patient voice. So at CanKids, for instance, we encouraged survivors of childhood cancer to become members. And we have a group of over 2,000 survivors across the country who are members of our survivor group called Kids Can Connect. We built up patient voice by encouraging our parents, bereaved parents, as well as parents of survivors to come back and become members. And that then allows you to start building up their ability to actually talk about what their issue is. Creating formal mechanisms at hospitals through, let's say, patient support groups at the hospital. The support group is not just a support group for people to talk to each other, or for the doctor to come and give you a lecture on patient education. Let's talk about health today. Let's talk about breast cancer today. Actually, that group is a group where you can, in a moderated forum, discuss the issues that you may be faced with. So if I'm really mad at the doctor, the example that I used, if I know that there is a patient support group in my hospital and that the patient support group is going to have a meeting, I would try to do this through that group so that there is a moderated discussion resulting in some change, some improvement for the patient. So from that aspect, building up that patient voice is one key thing that patient advocacy groups should do and are doing. And Ratnaji mentioned correctly that with the WHO and other organizations, for instance, building up the idea of people living with NCDs, citizens charters, talking about patient rights, all of this will help us to build up the patient voice. The second part of the patient advocacy role, and you talked about, a lot of us have talked about it. What else does a patient advocacy group do? Yes, it creates the bridge between the patient and the providers of healthcare. And that's important because I, as a patient, may not be able to spend the time on doing all the research I need to be able to go and make an argument to a pharma company or the government, right? Dr. Vinod Paul at Niti Aayog talks a lot about the need for patient advocacy. And he says, put together a case, but come with a full case, come with all the data, come with all the information, tell me what's lacking, give me patient stories, then I'll understand what the issue is. Individual patients may not be able to do this, but a patient advocacy group would put together the research, would find the cases to talk about, would then be able to put together a whole perspective representing the patients. So again, big thing that a patient advocacy group can do, but how many patient advocacy groups in the country today are actually being able to do that? So from a futuristic point of view, yes, we need to build this up much further.
All right, we need to build bridges as well. My question actually, Dr. Sukriti, was, is it making a difference? Because like Poonam ma'am mentioned, that we all look at doctors like, Bhagwan hai, unki daya hai ki wo hame treat kar rahe hain. We have to be grateful to them, indebted to them. How dare we demand you do this or how dare, and like she gave an example, but this is what is happening these days. Suddenly somebody is mad and they go pick up the doctor. So patient centricity, is it making a change? Because if I go to some of the private hospitals these days, I see the doctors are very busy and they don't have the time to, talk to all patients, but they do have an assistant who will help them with their appointments, will help them manage the patients, simple questions, which, they also have answers to. So maybe some progress is being made there. Patient centricity is important. We get feedback forms when you're getting discharged. Is this becoming a reality, or are we still living in that comfort of daya or treatment?
Is that for me, Anisha?
Yes, Sukhpreet.
Sorry, I'm losing your voice a little bit. Apologies.
Yeah, Anisha, yours, sorry, 1 second. Anisha, your signal is not very clear, so none of us are hearing you too clearly. Can you address?
I will try to fix it. Yeah,
we're all trying to figure out whether you're talking to which one of us.
No, but thank you, Poonam, ma'am. Thanks. Anisha, is it working? Definitely. Is it working well enough? No. I think like Mr. Tomer said, I think there's a lot of work left to be done. But I do think that kudos goes to the fact that these conversations are happening. And I'll give you an example. Patient advocacy groups do, of course, need to be represented and be inclusive of patients who've been on journeys, recovered, whatever that story is. Their voices need to be central to that. But patient advocacy groups can consist of policymakers, it can consist of scientists, it can consist of multiple other stakeholders. One example is tuberculosis. All of us would know of that journey that about a decade ago, it wasn't even a notifiable disease. You didn't even know how many people had it. And from that, really advocating with policymakers, including the Honorable Prime Minister and President, to making it a priority today, is because there were groups that came together to ensure that people understood that it's no longer a poor man's disease and you can't just brush it under the carpet. You have the world's highest burden and you better start addressing it. I do think that needs to happen in every area, and I just want to talk about one thing. I think we talk about physicality of patients, and I'm sure Poonam ma'am and Dr. Devi and everybody will agree. I think mental health care has been one of the biggest missed areas when it comes to really putting patient at the center. We talk about doses, we talk about journeys, we talk about have you recovered, we talk about how pharma is thinking. I think it's also time to really start talking about what is the mental health and why is that component important, and start working towards that, no matter which public health issue that might be. I'm going to stop here. Thank you.
All right. I hope, Arsha, you can hear me. Dr. Sukhpreet has given us examples of how patient advocacy is working. What more would you like to see? Because we still hear of incidences of patients being enraged, violence in hospitals. So that is very discouraging for doctors, because they are also doing their duty and their service in the best possible fashion. And sometimes some outcomes are not in their hands. So what is the next step? How can we make it, how can we give a voice to people who feel they have no voice?
So before I answer that question, I would also like to give you an example, and it is from the 1950s. It's about a cancer treatment that was done for breast cancer at one point of time, and that were radical mastectomies. So there was Dr. Hasted who had discovered this technique, and radical mastectomy is when complete breast and the tissue, the subsequent tissue there is also excised. And this used to have a lot of morbidity issues in patients. And this started in 1894, and it continued up till, I would say, towards the 1960s or so. And so, as the research and, as there's a talk around here, and Dr. Sukriti just mentioned that for patient advocacy, the stakeholders just don't need to be patients or patient groups. It is also the scientists. And so in history, we've seen that there have been scientists who have advocated for patients and, for the right treatments. So when this was seen, so at that time, the oncologists at that time, there were few oncologists like Dr. Jeffrey Kennis and Dr. George Kreil, who, when they were also treating their patients with radical mastectomy, and they saw that the morbidities were so high that they started trying other different techniques. And they saw simple mastectomy that Dr. George Kreil had started doing was having almost the same results as a radical mastectomy in stopping the disease, but it had much lesser morbidities. But Dr. Hasted's radical mastectomy was so well established that the surgeons and oncologists all over the world were completely sold by it. And it continued happening. And it was because of the patient advocacy groups at that time that were led by Dr. Jeffrey Kennis and Dr. George Kreil and other, other groups. And at the same time in 1960s, this thalidomide disaster had happened. And I'm sure everybody knows about thalidomide disaster and the kind of damage it did. And the pharmacovigilance was brought into picture. So, it was known that medicine or the medical industry is fallible. It's not like you are saying, Anisha, that, humbe daya ho rahi hai. So it was proved that, it is fallible. And so the patient advocacy groups talked about it, and the research done by Dr. George Kreil and Dr. Jeffrey Kennis bore fruit. There were more clinical trials that were done to prove their findings. It was after about about almost a century that radical mastectomy is not done anymore. The first line of treatment is always simple mastectomy for breast cancer. So if we ask about if patient advocacy works, it works. But as we are saying, we need stakeholders from all over. And as Ms. Poonam also mentioned here, that the Niti Aayog chief, he asks for complete data. So it is very important that this kind of research and the collection of data happens, and then the cases are made. Because as we say, one patient cannot really do anything. And so to the second question that you asked, what is it that we need to do? What should be the next step? So I would say the National Patient Safety Implementation Framework is already in action. It is a 7-year plan that Government of India has given towards implementation of patient safety in India. There are a lot of strategic objectives that are there, where it is about capacity building, good education, or I would say really holistic awareness or understanding to healthcare professionals, to patients, to consumer groups about patient safety principles. And there's also a lot of talk about setting up grievance redressal systems. And that is something that is very, very important, because where should a patient go to? And as in the beginning of the discussion, Dr. Sukriti also said, where should I go to when something happens? I've also gone through a patient safety issue, and I didn't know what to do. Should I go to the consumer forum? Should I go to the doctor? Though there are, in public health organization, we do have a grievance redressal system on paper. There's some work that is being done, but how much? But as a patient, I'm not aware of it. So that kind of awareness by the government agencies to patients and to consumer groups and to community at large is very, very important, so that we know that what our rights are and what we can do. And once we know that, and as I said, the Government of India in the implementation safety framework says until there is a demand, we cannot really, the policy change cannot happen. So I think there needs to be a collaboration among different stakeholders, among patient advocacy groups, and that would bring the solution first.
Right, but I just hope that in this day and age of the communication world that we live in, it doesn't take 100 years to bring about a change which is logical, which not just the patients have, even the medical practitioners see. Dr. Ratna, what impedes patient centricity? Because the patient safety program, this is the first time I'm hearing about this. I've heard this for the first time that the government has such a program. What impedes patient centricity? Stay at a hospital. Is it additional cost? Is it too much work? Is it not effective? What are the hurdles that come? Because it makes a lot of sense, you could follow practices that keep patients happier. Perhaps that will streamline your effort as well. So what is the impediment?
Okay, so I'll break this up into small parts because the impediment occurs at different levels. And in a way, I will also be sort of supplementing what Poonam said about collectivization, increasing awareness and bringing the patient voice to make policy change. So collectivization is not just about empowering patients, it's also empowering the healthcare providers. And let me give you a brilliant example. We were working on a condition which affects women's health. And the physician community or the physician forum that actually treats this particular condition were very, very deeply rooted in their belief and knowledge of what they were taught in their medical colleges on how to treat this condition. However, the world has gone leaps and bounds ahead, and those standard treatment protocols or advanced treatment protocols had not reached our country's shores because that kind of training to raise the awareness and skills of that particular physician forum wasn't happening. Or even if it was happening, it was happening to all the metro city, physicians who had the ability to attend those programs, whereas women's health is universal. So wherever there is a woman or a teenager, you need women's health. And so there was a lot of delay in diagnosis, up to 7 to 10 years in delay in diagnosis and 3 to 5 years delay in treatment. And that is extremely detrimental. And even though patients went and complained to their care providers that they are not getting the right kind of treatment, because many of these people are actually educated, can go to the net and surf and find out what's happening. But then they were confronted by their physicians saying, we know better than you. So when the patient group as a unified voice brought the other, physician groups from different parts of the world to a panel discussion with the physician group that was there in India, and there was an open discussion, there was some kind of agreement that there needs to be an urgent, capacity building of the physicians themselves before they can start talking about the patients. And that brought a sea change in the perceptions of how, patients are perceived when they complain that whatever is being given to them is either giving them a side effect that is not good or is not giving them the kind of results that they expect. And a lot of this is also because some of these advanced treatments are not available in the country. So that's the second impediment. Many of these innovator companies, because our country's reimbursement mechanism is such that the government pays only for the poorest of the poor and everything else is paid out of pocket, there is a perception that patients may not afford or will not afford, or even if they afford, they cannot buy, because we are a very price-sensitive country. And therefore, some of these innovative medicines are never registered in our country. So that is the second impediment that is there. The third is, because the patients are not aware that there are, or they are not even told by their care providers that this is a basket. You can choose the smallest that will give you maybe 60% relief, or you can choose the best that will give you 100% relief. But then the price variance between the two is 10 times more, and offer to the patient to choose which one they would like. That kind of offer is never made by the care provider. The care provider makes a judgment as to what could be the patient's capacity to pay, and then offers what is available with them based on that judgment on the capacity to pay. So that's the third impediment. You should offer the entire basket and say, okay, you choose what is best for you. And then explain to the patient what are the pros and cons of each of that therapy. And then the fourth impediment is, of course, paucity of time. If this much of explanation has to be given to the patient, the physician or the care provider has to spend a significant amount of time with the patient. And that never happens in our country, where time is very precious and doctors are in short supply. So there is a lot of, hurry that happens in a consultation. And then the last and the biggest impediment is health literacy. Even the most educated, quote unquote, PhDs are very poorly health literate. So even if they are offered the best treatments, or even if they are given the best counseling, they probably will not follow anything. So adherence is a big problem in our country because of poor health literacy. And therefore, we need to make people understand that health is their own responsibility. And while the system and the policy and everything else and the environment around them can provide everything that they need, at the end of the day, they have to own their health. So they have to change their lifestyle. They have to take their medicines on time. They have to go back to the doctor if something is not working, not switch doctors every time your medicine is not working for you. So several impediments. There is no short answer to it, but I think patient groups are making some change, positive change, at least in some of those areas to manage those impediments.
And Anisha, I'd like to go next, if you don't mind.
Yes, please go ahead.
Yes. So I'd like to just sort of, the way Ratna did, break it up and say, okay, what can we do at a hospital? I think all hospitals should be able to provide a support group and patient forums. And once you provide that as a mechanism, then you have a way of hearing your patient voice. Equally, and Ratna mentioned that an impediment is a physician often doesn't have enough time. Do you and can you provide patient navigators or care coordinators in your hospital so that in point of fact, there is someone to hold the hand of the patient, help them to understand what exactly needs to be done. We cannot as a country perhaps afford enough psychologists, but we can afford patient navigators. So if we built that up within the patient advocacy scenario for a hospital or an institution, the institution would then be able to create platforms for moderated listening. And I have seen this, we do it ourselves, but at the Tata Hospital, every month, all the doctors are on stage, they hold a parent forum, all the patients are in the auditorium, and the doctors actually give that time. So everybody within the scenario now knows that once a month we get to tell the doctors what we want to tell, and they get to explain to us in a moderated way how to tackle a particular issue. Coming to research, which is the second piece that patient advocates need to do a lot about. Again, if we want to have better healthcare, we want to promote drug improvement, protocol development, etc., then patient advocacy groups have to build up ability of patients to know and understand research and to be a good part of a research team, or for that matter, an ethics committee. So unless you actually educated patients to become that, how can you represent in a, let's say, in a research group? So again, educating, and you mentioned that, Ratna, in terms of health literacy, but I would also say research literacy, which is critically important if we want to improve our healthcare. If we talk about policy and patient advocacy for policy, then we have to look at it at the regional and the national level. So I'm going to give you an example. My survivors for 5 years got pledges for We Want Childhood Cancer to be a child and health priority in India. This was a journey of stakeholder engagement for all of CanKids and the work we did. We did engage a lot of stakeholders, but there is no platform where these petitions can be given to the government of India. So my survivor group for 2-3 years has every year been writing to the health minister, writing to the health department saying, can you meet us? Now they're willing to meet for everything else, but I've actually had a government officer tell me, we don't want to do all this. It's okay. There is no need to have patient advocacy. So there's a contrast, right? We do need to, even the government or the policy maker needs to be comfortable to be able to listen to the patient voice and recognize it's important. But can we create mechanisms whereby if patients want to address it, someone spoke about it as a grievance mechanism, but maybe it's not a grievance, maybe it's a policy related issue. How do we bring it forward to the policy maker at the state government level or at the national level? And finally, talking about patient advocacy and the media, because the media plays a very, very big role when it comes to, can we create awareness? Can we drive demand, as we put it? Can we talk about patient rights? Can we talk about the right to health? So what can we do as patient advocacy groups, and what can we do with the media? Is there educated media that understands and gives an opportunity, or is there media that simply publishes a story? I meet journalists all the time, and sometimes they say, "Acha, kahani bata do bachche," because bachche bahut achhe emotional hai, and we'll do a nice little story for you. But what about the issue? What about the bigger story of it? So do we have an educated media that doesn't just do Sansani case cover, but actually takes it up and prints, publishes at the right time to be able to create a stronger patient voice? So I think those are some ideas that I've had that I think need to work in different spheres to improve the impact of patient centricity in healthcare.
All right. Vivek, for patients, how do they find each other? Because like many of the panelists said, a lone voice gets no ears, right? So if I have a grievance, if I feel my care was lacking, as patients, how do they find that support, and how do they make their voices be heard?
Okay, so I think I respectfully beg to differ in some of the points, including a lone voice cannot make a difference. A lone voice can make a difference, but yes, we need data to support that lone voice. So when my wife, who has lung cancer, non-smoker lung cancer, a very rare lung cancer, and she was on that bed, there was not a single medicine. And what I learned during this journey when I was trying to save her, that patient advocacy is a reaction chain. One has to start. So I started with the journey to pure self-reason to save my wife. And despite that rare cancer and despite the stigma of lung cancer with smoking and no support, not a single lung cancer patient advocacy group. This became the first lung cancer in India who has all the medicine available within 2 years, that is ALK lung cancer. We became the first group, and that's a chain. Then many people joined. Not only lung cancer support group, we have developed, and that's how they're connected, India's and Asia's first oncogene focused support group, where we are not talking just lung cancer, we are talking of particular mutation, and their data is generated. The good thing about India is there's nothing rare. So we talk about rare cancer, rare disease, nothing rare because of our population. And we have to take advantage of this because you can generate data. I also beg to differ that things can't move easily, or there's a lot of blame. There's a lot to blame. The other area I started as my patient advocacy is clinical trials, cancer research. And when I started this work in 2012-14, there was huge stigma of guinea pig. And even my fellow patient advocates were not open for this topic. But when they understand, they become patient advocate, and others can understand, because if we don't have the latest medicine, we can't have the latest treatment, we can't survive. So from that reaction, it's important to help each other understand. And one last point is, I believe that there are good and bad all places. I agree that patient voice is not yet on the center of the table. Forget the forefront. This is a brutal fact. I agree with one of our panelists from Cancer Kids when they say they want a story of sympathy, and I'm very against. Yes, we need the story to make it humanized, but not for sympathy. I personally declined at least 90% of my invitation from the medical conferences because they want us patient advocates to come at the last of the session or first of the session and tell the story when no one was there to listen. There is nothing to support and help. If not,
just small request, sir. On the alien link, we request.
Sorry. So when we wanted the central level, we want just hear us with the data. And the last thing, and then I stop with this message. I find there are good and bad people everywhere. There are supporters and non-supporters everywhere. Be it government, be it media, be it patient advocacy, be it hospital doctors. There among 100, there were 4 goods. Just connect with 4 goods. And what has happened that within this year, like in our case, we bring all the medicine. The one medicine cost was, every medicine cost, minimum cost was 11 to 15 lakh per month. They are now in India, innovator medicine as well. 35,000 rupees per month. At least a middle class now can afford, if not poor. And for poor, we work with the government to bring them in the Ayushman Bharat. So that's how things can change. just find the right people, present the data, and just keep banging the door until they hear you, because they don't change until they hear you. So thank you. You are on mute, Anisha.
Dr. Sukriti, would you like to give us a few more examples on how patients can really make a difference? And patient centricity is something that now everybody is waking up to.
Sure. Very quickly, I know we are running short of time. We all know what's happening in US with Roe versus Wade. But at the center of it, remember that it was somebody who went through that experience and took on the entire judiciary and the government to place abortion rights at the center of the narrative. I think there are multiple such examples in India as well. In fact, I just want to say that, you started by saying that there's this attitude, Dr. Bhagwan hai. I don't think any human is God, but I think doctors really are one of the most critical and selfless members of this society. And I think COVID has shown us that. And I think due credit needs to be given, not only to doctors, but to nurses as well. I just want to give you an example quickly of the work that we've done as ETHI. When COVID-19 vaccines were not made available to pregnant women, I don't know how many of us know, but there were deaths by the measure which were not reported. There were women who needed that access. It was the doctors who came together, and it was the scientists who we worked with to really turn that curve within 10 days. And when you go out there and you realize that advocacy, yes, patients need to be centric, but there are going to be examples world over where you'll see that it's not only the patients, and I agree with Vivek, it can start with one, but we as people on this call need to make a commitment that we are here because we have a responsibility squarely on our shoulders to be conduits of change. And if we are not going to stand in the center and create those bridges, what are people who don't understand anything about rights or access going to fight for? So I think that's the message I just want to leave with, and thanks for having me again.
Right. I'll take a couple of more concluding remarks. Arshia, would you like to go next with your last word on the importance of patient centricity?
Yeah, so I would like to give a recent example there that has been in India as well about increase of age towards abortion from 20 to 24 weeks. And it was Dr. Nikhil Datar, who's a very who's a very acclaimed gynecologist, who challenged the government of India, and it's a consumer case that is there. Dr. Nikhil Datar versus government of India, the Indian Union, and the ruling was passed in 2000. I think he had put this case forward in 2017, and the ruling was passed. The bill was passed by Government of India in 2020 that and he had won the case that the age of abortion for women would be increased from 20 to 24 weeks. So so he advocated for women and how important it is for women to have the right to abort a child if they do not want. And as Mr. Vivek said, it's about it's one patient's voice or one person's voice also that can make the difference. So this is one of very big examples there. I would say patient centricity is really the need of the hour, and I've been writing about it, and one of my articles was recently published in a WHO publication, Uppsala Reports, where I talked about that how it is important for patients to be treated with as much respect, because as we're talking about patient centricity, it cannot come if the patients when a patient talks to the healthcare provider about their treatment options, and usually the response is you're not the expert, or we listen the statements like that, oh, you've studied Google, you come from the Google University, or you're a Google doctor. And there are a lot of patients, though I understand there are a lot of patients who are misinformed, who have come, who have read from inauthentic sites, and it becomes quite a frustration for the healthcare professional to answer those questions, or to convince them what is right or what is wrong. But there are also patients who have a lot of understanding, about healthcare, or as Dr. Ratna Devi say, are health literate. So until their there is due respect given to patients' views and their right to their treatment options until they are given complete information about what could be the complications of the procedures, and if they want, if they're given the right to informed consent or not. True patient centricity cannot be achieved. At this point of time, it is very, very important that we become a patient-centric society or a healthcare system, and I think it's important to advocate for that. And yeah,
right. Dr. Ratna, your last words on patient centricity. Is it in the hands of healthcare providers? Is it in the hands of patients? What would you like to say?
Thank you. Just one small statement before I address that question. And this is to, what has been discussed over the last 10 minutes or so. Sometimes, people on panels sitting like this think that the patient is somewhere on the moon. We are all patients, and we have all experienced a hospital or gone to a healthcare institution or gone to a doctor. And it is finding the champions amongst us that will unify this patient voice and bring the cause to the forefront. And having said that, because I work with multiple patient groups, I've seen, good doctors, good engineers, good lawyers who have gone through this journey come forward. And when they come, so for example, I have a type 1 diabetes patient who's a pathologist. I have a Parkinson's patient who is an ophthalmologist. I have a stroke survivor who is a radiologist. And when these people come and speak as patient advocates, I have a lawyer who is a diabetic and who's trying to change policy for storage of insulin in workplace. Allowing destigmatization for taking insulin in workplace and storage, creating mechanism for storage of insulin in workplace. So when these kind of intellectuals come forward and become champions, the whole advocacy takes a different face altogether, because then these people cannot be challenged as saying, you are a novice, you don't know anything. So we need those kind of champions to come forward. And when all these people get together and there is enough collectivized voice, I'm sure that this whole patient centricity and talking about patients as an individual human being and not as a collective like we read in our textbooks becomes more of a reality. So patient centricity is important. Patient centricity is not about one person, one profession, or one stakeholder. Everybody has to come together, because the center of patient centricity is the patient himself. So whatever touches that patient, whether it's the policy, whether it's reimbursement, whether it's hospital, whether it's drug manufacturing, whoever touches that patient has to bring that perspective of patient centricity to that particular profession or industry, and then work around it so that the patient is not somewhere on the outside, as a beneficiary, but is actually the one driving the change. I will stop there. Thank you.
All right. What would you like to say, Poonam ma'am, in the last?
So I'd really like to say that if we're talking about patient centricity, I would like to advocate that the right to health becomes a fundamental right in India. And I think just like the right to education became one, if we did that, and if we all advocated for it, much else would change, because it would drive the next level of change. A lot has happened during COVID. As somebody mentioned, the healthcare space is exciting at the moment because of the kind of change we are seeing. Yes, if we want patient advocates to be heard, we have to have many, many more of them. And therefore, building up the patient voice, building up patient advocates. Ratnaji, you said we need the specialists or the more intellectual people to be that voice. But I think the voice of Saksham's Dadi is as important. And can I do something to help Saksham's Dadi's voice be heard is equally important. So I think with that, I'd like to say thank you very much for having me today. And I'm really delighted that these conversations are happening. But Ratnaji, yes, I agree with you. They shouldn't just be on a panel. They should be about the patients, and we should hear much more of the patient voice. Thank you so much, Anisha. And
a big thank you to all of you for joining us to talk about patient centricity. And let's hope this is something that is spoken of more frequently, not just amongst patients, but by care providers, be it drug companies, be it hospitals, or be it diagnostic companies. And let's hope this all becomes more mainstream, because this does help a lot of people, and even the policymakers are now on this job. Thank you all for joining us. Thank you, Dr. Sukriti. Thank you, Poonam ma'am. Thank you, Vivek, Dr. Ratna, and Arshia. Thank you all for joining us this afternoon to talk about patient centricity. What we're going to do now is take a little break. Just a reminder to everybody who's watching, do follow us on Facebook to get all our updates on the upcoming programs that we do. And we do a lot on good health, good lifestyle, good air, good water. So make sure you stay tuned to all that we have posted on our Facebook page. We'll take a short break and we'll be back very soon with something that all of you are waiting for.
Thank you.
gentlemen, I'm Anisha Nair Thapan, and it's an absolute honor and pleasure for me to be present here. Integrated Health and Wellbeing Council is delighted to bring to you the first edition of the IHW Patient First Awards 2022. I would request all of you to keep your videos on and your mics on mute. Now, after a session of many discussions and deliberations, panel discussions on the most important and sought after segment of the healthcare delivery mechanism, the patient centricity and advocacy, which has to be and will be the key drivers of modern healthcare delivery system. Now, we thank all our dignitaries and key speakers for sharing their thoughts and ideas. Ladies and gentlemen, now we have the most awaited section of the day as we present the inaugural edition of IHW Patient First Award 2022. The Integrated Health and Wellbeing Council is a not-for-profit institution aligned and inspired by the UN Global Agenda of Holistic Approach to Social Development Goals. We feel extremely proud to drive 9 out of 17 SDG goals through holistic, high-five health awareness, advocacy, and action agenda of the IHW Council. Our belief and principle reflect in our high-five missions to achieve good health, good food, good water, good air, and good lifestyle for all to create a world of cross-domestic health and well-being progress. The advocacy and awareness impact we have created in the last 7 years through the responsible actions of our missions involving global leaders, countries, relevant ministries and government bodies, health, environment, and education policymakers, medical technology solutions and services, infrastructure pioneers, researchers, academia, professionals, health enthusiasts, and key influencers, and stakeholders, and the grassroots level organizations has been a sheer passion. It is our extreme pleasure and privilege to conceptualize and organize such rewarding initiatives for healthcare providers, individuals, patient centricity organizations, advocacy groups, and agencies engaged in such remarkable, sustainable, scalable, responsible work for humanity and uplifting the health of communities and societies at various fronts. These recognitions from India's premier health awareness and advocacy group will bring to the fore the credible and outstanding contribution of institutions, organizations, healthcare service providers, all levels of patient groups and individuals focused on various illnesses and diseases to bring patient centricity and advocacy to the core of health and healthcare systems. IHW Council, with its inaugural edition of IHW Patient First Award, aims to highlight the positive change and the focus of these organizations, groups, and individuals that are striving to bring about this permanent change in reducing health disparities, providing much needed care and guidance to patients at all stages. In this edition, we have received more than 92 nominations, and IHW Awards team has evaluated and screened more than 38 final entries and presented them to the respective jury for their further evaluation. It is just that we have a process of selecting winners. It doesn't mean that the efforts of others is less or more. For us, all initiatives are remarkable and valuable, and we request all to continue this encouraging work, irrespective of their selection to this year's award. It has been a tremendous amount of work and planning that has gone into making this day possible. And I would like to thank all our partners for making this evening come alive and is so special. We are extremely grateful to our esteemed jury members, each of them a highly decorated and recognized public figure and decision takers, promoters, and propagators of good health. They have given us incredible guidance and support to recognize the efforts of deserving organizations working and contributing. Dr. A.K. Bhalla, Chairman and HOD, Department of Nephrology, Sir Ganga Ram Hospital, New Delhi. Dr. Govind Babu, Medical Oncologist and President, Indian Society of Medical and Pediatric Oncology, 2019-2022. Dr. B.G. Dharmanand, rheumatologist and president, the Indian Rheumatology Association. Dr. Devashri Danda, professor and founder of the Department of Clinical Immunology and Rheumatology, Christian Medical College and Hospital, Vellore, India. We have Dr. Rishikesh Pai, gynecologist and president-elect, Federation of Obstetrics and Gynecological Societies of India. Dr. Jayaraj Pandyan, principal and professor of neurology, Christian Medical College, Ludhiana. Dr. Padma Srivastava, head Neurosciences Center, All India Institute of Medical Sciences, New Delhi, and Ms. Urushi Prasad, director, Development Monitoring and Evaluation Office, NITI Aayog. A very big thank you to all of you, all the participants who have wholeheartedly supported this initiative by being present today. So without any further ado, let's begin the celebrations of the IHW Patient First Awards. To start with, I would now like to invite Kamal Narayan, CEO of IHW Council, to say a few words about this initiative and what the IHW Council hopes to achieve from this. Kamal.
Thank you so much, Anisha, for the introduction, and welcome all our speakers, jury members, and all those who have gathered today with us, and their work is going to be recognized. For us, patient centricity is not only about treating diseases, it is about treating a person as a whole, and it must also take into account the pains, the expectations, belief, and the wishes of the patients who are undergoing the treatment. And it shall also endeavor to involve the patient in the healing process and empower them with the freedom of choices. And that's what is the agenda, the pursuit of Patient First Summit and Patient First Award initiated by IHW Council. Researchers also have shown that just hearing a patient properly and let them describe the conditions as they experience itself makes a lot of difference in the outcomes, in the health outcomes. However, in our resource-crunched healthcare system, where our vital public hospitals are overcrowded, this primary practice itself of listening to a patient has become an unaffordable luxury. And it is not that doctors do not want to do that, but have to ignore, as they may end up doing this on the cost of many other queued up for hours in front of their OPD. And that's what has been the one of the major takeaway from the various sessions we hosted during the day today. And we can also see the similar scenario in a much better of private hospitals, as their incentives seeing more patient can be more quote unquote commercial as we look at it, but the challenge lies in the whole system, and the reason may be for many, but the clear way forward for any healthcare system which wishes to be efficient and empathetic is to adopt and nurture a patient's first approach. And a patient-centric healthcare system must empower also patients to be more conscious and caring and contribute to their own health and well-being. Much like raising a child needs a whole village, delivering patient-centric care requires an empathetic approach and proactive participation of entire healthcare ecosystem involving doctors, nurses, hospital managers, drug makers, and even government leaders planning for public health. So, and this much needed transition will not be possible without the committed push of patient advocates and, who believes that no disease shall remain neglected and no patient shall be left behind. IHW Council is proud to be one such advocate like all of you. And this made us, convene today this unique Patient First Summit and Awards. We strive to put the patient's interest and right at the center of our healthcare system with this initiative. These awards today are a small way to recognize the visionary approaches taken by many care providers in nurturing patient-centric approach and preserving patients' rights, along with celebrating the arduous journey of many patient advocates fighting for this cause. I'm aware that thousands of individuals, organizations, and groups struggle every day to instill patient centricity through their patient support advocacy for numerous diseases in India. And I'm sure going forward, we will be able to know more about them and showcase and celebrate their work for patients as well. And I congratulate all those being recognized today and hope they will become the ambassadors to encourage many more to follow in their footsteps and make patient centricity the cornerstone of Swasth and Ayushman Bharat. Thank you so much.
Thank you, Kamal, for your opening words. Truly, this is going to be an evening to remember. And not just with the awards being given, but we'll also be joined by the Honorable Minister Shri Ramdas Athalke, Union Minister of State for Social Justice and Empowerment, Government of India. And of course, to all the award winners, this is totally be a timeless evening for them to keep in their memories for a really long time. So let's start and get this show going. We are going to begin with the organization nominations under specialty patient centricity. So let's start with our first award in the patient centricity for diagnostic lab category. And the first award goes to SR. The first award goes to SRL Diagnostics. Heartiest congratulations to the team at SRL Diagnostics. We would like to invite Ms. Nadia Mali to receive the award. Ms. Mali, if you're with us on this call, we request you to unmute yourself and say something shortly about the award that you've received. Okay, let's move on to our next award. And when Ms. Mali joins us, we will give a chance for her to speak. Let's now go to our next award, and this is patient centricity in mental health category. And the winner is Lupin Limited. Heartiest congratulations to Lupin for winning in the patient centricity in mental health category. I would like to invite Amitabh Pandey, Ramanand Prabhu, and Harshul Shah to please accept this award.
Yeah. Yeah, thank you. Very good afternoon, everyone. Myself, Amitabh Pandey. I'm General Manager with Sales and Marketing for the Lupin CNS. So thank you so much on the behalf of Lupin. I thank you, IHW Council and entire jury for acknowledging and considering our patient awareness initiative. Say Yes to Life campaign in the space of mental health and according the same. This surely means a lot to in our efforts and as an organization. We at Lupin have always been in the forefront when it comes to create awareness and bringing patient centricity to the priority, which further improves the healthcare ecosystem. Mental health, as of all of you know, mental health still remains a taboo in the society because of the stigma associated with it. It inhibits people to speak out who are struggling with depression and other mental health disorder. With our Say Yes to Life initiative, we relentlessly working together with HCP to up this gap. We'll continue to striving bring permanent change in reducing the mental health burden and disparities in India, providing such needed care and guidance to the patient at all stages. Again, we thank you to council and jury for the award. Thank you. And I also would like to thank you, my team, particularly Mr. Harshul, who has been the forefront on this, and Mr. Ramanand and our entire team. So, this award will definitely help us, encourage us to do better in what we are doing. Thank you so much. Thank you, everybody.
Congratulations.
Thank you. Heartiest congratulations to the Lupin team. And these awards should be motivation for everyone to do their best. Let's now move on to the third award of the day, and this is patient centricity in non-communicable diseases. And And the award in patient centricity in non-communicable diseases goes to Zydus Lifesciences. We would like to invite Ms. Parul Sood, Mr. Kanan Indran, and Mr. Sanjeev Roy Chaudhary to please receive this award.
Thanks a lot for considering and for rewarding and acknowledging the good work which has happened in the asymptomatic disease which is known as the non-alcoholic fatty liver disease, as well as the NASH, which is the future for the next 2 decades, which we will evident with the 2-hour sedentary lifestyle. And certainly a lot of good work has happened in terms of awareness, both in India and globally prospective, with more than 1 million followers and all the part of to be the awareness to that. And certainly NASH is a multidisciplinary organ disease where all the vital organs are associated with the liver being the powerhouse. So being an awareness, keeping ourselves healthy and being to be the part of the healthy lifestyle, your liver the powerhouse should be healthy. So that's a whole endeavor what we are been working on it with as an organization as a Zydus to communicate the non-communicable disease through various awareness part, so that in our day-to-day lifestyle we become much more healthier and we bring a healthier community for ourselves and for the next generation for what we do bring in. So good work has been done by our colleague Parul. She has been the torchbearer to work on this, and certainly this has helped all of us to bring the awards. So thanks for you, thanks for considering, and thanks for rewarding and acknowledging the good work has happened in this space.
Cheers. Congratulations to the Zydus team. Let's now move on to the 4th award for this date, and the category is Innovation in Patient Centricity and Advocacy. The award in the Innovation in Patient Centricity and Advocacy goes to Metropolis Healthcare. Congratulations. I would like to invite Dr. K.T. Chadha, Chief Scientific Officer, Metropolis, to please receive the award.
Yeah, on behalf of Metropolis Healthcare Limited, I would like to thank the IHW Council for felicitating us with this prestigious Patient First Award. It means a lot. We congratulate the Council and thank you actually for creating this awareness and this advocacy for a healthier, happier world. And just like you, we also believe that optimal healthcare is each of our responsibility, including the patients. And that is why we try to contribute, nationally and internationally throughout our entire geography that we service. And this is a very, very special test, which is very close to our heart. And, the number of special children born in India is very high. And that is what we try to take care of by, we want to reduce this incidence of special children through a very, very scientific, reflex, economic diagnostic testing in pregnancy. And I would like to thank each and every metropolitan who has contributed in making this a success, and all the gynecologists and obstetricians of the country and abroad who have actually, percolated the message to their patients and helped all the pregnant women. I shouldn't call them patient, pregnancy is physiological. So all the pregnant women, to have a healthy baby. That's all. Thank you so much.
That is, congratulations to the Metropolis Healthcare team. Our next award is in the Startup in Patient Centricity and Advocacy category, and this is the 5th award of the day. And the winner of the Startup in Patient Centricity and Advocacy category is Hatch & Coolers Limited. Congratulations. I would like to invite Garima Vyas, Anna Parker, Ramesh Shetty, and Catherine Daniel to receive this award. Garima, you're on mute. If you can unmute yourself, we can't hear you.
Yeah, hi everyone.
You'll remember the reason.
Hi everyone.
I will request everybody else to please mute yourself. Please, everybody else, please mute yourself. And Garima, go ahead.
Thank you. So I'm really grateful for the jury, for everyone to select this award and to honor us this award. I would just like to give a brief idea about the Paxman scalp cooling. You must have heard about the alopecia, the side effect of cancer, right? So now when we have quality drugs, we have advanced drugs regimens, we have advanced diagnostics, the quality of life to the matters to the patient. So now we have Paxman scalp cooling by 50 to 70% for chemotherapy patients undergoing. So you can read about our Paxman scalp cooling on coldcap.com. And thank you so much for everyone. Please spread the word for all the cancer patients you come across, you know, and wherever you go, that now they do have a support to live a good quality of life with preventing the hair loss. Thank you so much, everyone. And it's very encouraging, inspiring to be with you all. Good luck to everyone. Thank you.
Congratulations.
Let's now move on to our next award category. And this is the first award in the patient centricity in pharma. And the award goes to the first award in the patient centricity in pharma goes to Bayer Insights Pharma Private Limited and Patient Academy for Innovation Research. Heartiest congratulations. I would like to invite Mr. Deepak Chopra, Dr. Ashish Gavde, Dr. S. Ratna Devi, Dr. Uppal Vyas, Ms. Roshni Atawar, Ms. Siji Nair Kaul to please receive this award.
Yeah, hi, thanks. This is Dr. Uppal Vyas here from Bayer, and I would like to thank our seniors, Dr. Ashish and Mr. Deepak, and my colleagues, Ms. CG, Roshni, and Javed, and of course, and most importantly, our partner for this project, Dr. Ratna Devi ma'am, and the Bayer team. Thanks so much. Also, thank you so much to the IHW team for recognizing our efforts. And probably at this point, I'd like to request Dr. Ashish sir and Dr. Ratna ma'am if they would like to share a few words, please.
Thanks, Uppal. I'll be very quick because I would like Dr. Ratna madam to speak here. But I just would like to say one thing, that usually we always say that patient is at the center of whatever we do in Bayer. And that's why this type of award really gives us that kind of a motivation to continue working with those patients, bring those innovative solutions for these patients. And that's how we can try to make their life better. Over to you, Dr. Ratna Devi.
Thank you, Ashish, and thank you, Uppal and Deepak. You know, if I'm the head or the brain for this project, my heart is with my team, which is Kushbu, who leads this whole initiative, and Ankit Dabra. So they are the ones who actually do the work on the ground. So heartiest congratulations to them. And thank you for trusting us and for believing in us. And thank you to the jury for considering us worthy of this award. So we will deliver even better in the future. Thank you so much.
Congratulations, Dr.
Thank you, IHW.
Congratulations to the entire team. We're now going to move on to the 7th award of the day. And this is the award in the patient centricity in pharma category. And the award in the patient centricity in pharma category goes to Cipla. I would like to invite Mr. Makaran Yadav to please receive the award which has gone to Cipla for patient centricity in pharma category.
Thank you, Anisha, and thank you so much, first of all, for this award and recognition. So thank you so much, IHW team. Moreover, in this category of a CSR, as a Cipla, we all know and we are aware about that Cipla is always for the caring for life. And the caring for life is for all the category in all the patients front, we are always there. And as a therapy, when we are talking as a nebulization, it is our main motto to reach this nebulization therapy, need to reach each and every corner of India. And that's why we are working. And with this particular project, we have reached out of 5,000 CSC, PSC, where the nebulization therapy is reached because of this project. So thank you so much for this particular recognition. And in that, my team, I just want to give the congratulations to the team the brain behind that, the execution part behind that, that is Mr. Shubham Sharma. And also I just want to say thank you to Mr. George Varghese, Mr. Darshan Shah, and with that, my sales and marketing team for this particular fantastic execution in this particular project. So thank you so much for all my team, marketing and sales team. And thank you so much ISW also for the recognition.
Congratulations.
Heartiest congratulations to the Cipla team. We are now going to move on to the category of data and pharmacovigilance. And we have our next category, which is data and pharmacovigilance. And the award goes to the award in the COVID diagnostic brand category goes to Kamineni Hospitals Private Limited. Congratulations to the entire team. We'd like to invite Dr. V. Gokul Raghuram and Dr. Prerana, Dr. Jaya Kumar, CD, and Mr. Surendra to receive the award.
Good afternoon, everyone. Greetings to you on behalf of Kamineni Hospitals, Telangana and Andhra Pradesh. First of all, I would like to thank the organizers for giving us this opportunity to nominate one of our best practices as a project submission under the drug safety and pharmacovigilance category. Our sincere thanks to the esteemed panel and ISW Council for this award. It's an honor to be recognized among the best in our industry, and we are very much delighted for it. With this enthusiasm, we will take up more initiatives and continue our good work, putting the patient first, which is always our prime motto. We shall nominate our hospitals in more categories in the coming years to announce our best practices to the industry. We also like to thank and congratulate our team for their efforts. We will take this opportunity to congratulate all our fellow winners and nominees. Congratulations to you all. We once again thank the panel and the ISW Council for selecting us for this award. Thank you, one and all.
Heartiest congratulations. Let's now move on to our next award. And this is the award in the category of education and training for patient centricity and advocacy. And the award goes to Cipla and Shpang. Heartiest congratulations to the winner in the category of education and training for patient centricity and advocacy. I would request Ms. Ashwika Acharya. The award winners are Cipla and Shpang agencies. So I would request Ms. Acharya to please receive the award.
Thank you so much. I'm delighted to accept this award on behalf of the entire Cipla team and a special mention of our media partners, Shebang. Thank you to ISW Council, Patient First Awards and the jury for recognizing the Inhalers Hai Sahi campaign, which is a patient awareness initiative that aims at increasing awareness on asthma and inhalers as its right treatment. We are very happy to be receiving this award. Thank you very much.
Heartiest congratulations and thank you for joining us. Now we are going to move on to the individual and NGO nominations. So in the specialty patient centricity, the gold award for patient centricity in non-communicable diseases goes to the award goes to All India Institute of Medical Sciences and ICMR, New Delhi. Congratulations to the team. Our next category is innovation in patient centricity and advocacy. So the next category, innovation in patient centricity and advocacy, the bronze award goes to A Walk with the Doc India. Congratulations. We would like to invite Ms. Rajvi Menon to please receive this award. Would request you, Rajvi, to please unmute yourself.
Hello, am I audible? I'm Anusha. I'm not sure if Rajshri is online.
No,
I think she
Rajshri is
dropped
with us.
off.
We can see Rajshri, but we can't hear her.
Oh, you
Please
you
go
can't
ahead,
hear
Anusha.
her, is it?
Yes.
Okay, Rajshri is my colleague. She heads actually healthcare at Goki. I'm Anusha, who heads content and communication. And Rajshri, are you there?
Which name you have called for? What's the full name?
Walk with the Doc. It's part of the Goki initiative.
And we see Ms. Rajshri Menon. She is on
Yes,
this
my name is
podcast.
Anusha. I'm also from Goki and a part of the Walk with the Doc initiative. Rajshri Menon heads healthcare, business and healthcare at Goki, and we started this initiative specifically where where patients walk along with the doctor to build that camaraderie between patients and the doctor while okay, to build a camaraderie between patients and the doctor in an atmosphere which is not the clinical atmosphere. And Walk with the Doc was an initiative where we realized that doctors keep asking patients, to, along with medications, to go for walks and everything. But, seldom do patients really adhere to those. But we thought that if we do an initiative like this, and this was an initiative which was first started in the US, and Rajshri was instrumental in bringing this down to India. And Goki was that. Yeah,
this is a great
started
initiative.
by a cardiologist in the US, and Rajshri was, she kind of spoke to him and brought this initiative. And Goki is a preventive healthcare company, which was kind enough to actually lend their platform as well. So we
Thank
did
you
a couple
so much,
of.
Anusha. Thank you, Anusha.
Thank you. And thank you so much, IHW, for giving us this award. It was one of its initiative that we did, and we are extremely glad to receive this award. Thank you so much.
Right. Now, in our next category of the innovation in patient centricity and advocacy, the Silver Award goes to the Silver Award for innovation in patient centricity and advocacy goes to Sanjeevni Life Beyond Education and Training. Congratulations. I would like to invite Ms. Ruby Ahluwalia to please receive the award. Mr. Ahluwalia, could you unmute yourself? I see Mr. Anil Ahluwalia.
Yeah, that's right. Hi, good afternoon, everyone. I see Ruby is filling in for a medical emergency at home, so I am just filling in for her. So thank you, Kamalji, thank you, Anisha, the team of ISW and the jury for this recognition. Means a lot. And I must say that every nominee I've been listening to the work that has been happening, my respect and salute to everyone who is doing this wonderful work as far as working for the patients is concerned. Sanjeevni works at a bigger spectrum, from prevention to rehabilitation to counseling, blah, blah, blah. And I'm happy that the team is getting recognized. I see some of our team members here. So congratulations to all of you also for the excellent work that you people are doing. Well done. Sanjeevni Angels, keep the flag flying. Good. So a big clap for all of you. Thank you.
Thank you so much, Mr. Ahluwalia, and everybody at Sanjeevni. Keep up the good work. Congratulations. Let's now move on to the Gold Award for Innovation in Patient Centricity and Advocacy. And the Gold Award for Innovation in Patient Centricity and Advocacy goes to Dr. Bindu Menon Foundation. Heartiest congratulations. We'd like to invite Dr. Bindu Menon to please receive the award. Ma'am, I'd request you to please unmute yourself. Yes.
Thank you very much for giving me the award for the patient advocacy. It's a pleasure to receive, and I suppose that award and getting an award itself is motivation to do more to the public and getting more innovative ideas so that we can reach the rural population and the interiors of the villages where we see that there is a lot of rural and urban divide. Hopefully things would get, and I suppose this is also an area where now we also know that the World Health Organization is going to table a global action plan against neurological disorders, and it's going to be tabled in May 27th. And this is one incentive that all of us together need to work towards decreasing the morbidity and mortality of neurological disorders, because as we know that neurological disorders are being ranked first among the morbidity and second among the mortality in all across the globe. That's why the WHO, the World Health Organization, has taken up this initiative to table up. And I suppose we in small ways, all of us are contributing ours, and your organization is doing the maximum to put everything under one umbrella. Thank you very much.
Thank you, Dr. Bindu, and congratulations. Let's now move on to our next set of awards, which is for the category of education and training for patient centricity and advocacy. And in this set of awards, the first one is the Bronze Award for education and training for patient centricity and advocacy. The Bronze Award for education and training for patient centricity and advocacy goes to jayakara.org. Congratulations. We would like to invite Ms. Gurvinder Kaur to please receive the award.
Thank you very much. I'm glad to be here among so many wonderful people who are doing exceptionally well. Being a stage 4 warrior, I myself has gone through a lot of difficulties getting right information at the right time, which made me more firm, spreading awareness about all the consequences and the situations which a cancer patient faces. Especially somebody talked about the mental health, which is always a taboo. People always feel that cancer patient only needs sympathy, but it is not that. If a cancer patient is dealing with cancer itself, they have a lot of courage and they know what they are dealing with. So they don't need sympathy, they need support, they need right kind of information. And I'm glad that everybody on this platform is sharing and doing the best part of their work by spreading awareness and advocacy and providing right information at the right time. I think that is something which everybody needs, especially the cancer patients. I would like to thank IHW Council for this amazing awards, which is definitely gonna boost our confidence and motivate us to do way more in helping people out there. Because in India, I would say now people are coming out of their shell and they are being more vocal about this disease. Because in most of the area, like if we talk about when we work in a ground rooted level, when we reach to people's house and they say, we don't want to talk about cancer. Even if we call cancer, maybe this disease will come to our house. So this kind of a mindset people has. So it is very important to be vocal about it. And again, I would like to thank IHW Council and the whole panel jury for acknowledging our work, and thank you very much.
Congratulations, Gurvinder. Keep up your good work.
Thank you.
Let's now move on to the Silver Award for education and training for patient centricity and advocacy. The Silver Award for education and training for patient centricity and advocacy goes to Taram Chetna Sansthan. Congratulations. I would like to invite Mr. Naseem Ansari to please receive the award.
जी बहुत बहुत शुक्रिया। मैं हिंदी में बात करूंगा, यूपी का हूं तो हिंदी में बात करना जरूरी है। बहुत बहुत शुक्रिया। ये मेरे लिए एक बहुत अच्छा एक क्षण है ये जो मुझे अवार्ड दिया जा रहा है। इसके लिए मैं जूरी के जितने साथी हैं उनको मैं शुक्रिया अदा करना चाह रहा हूं, और फिर ISW काउंसिल के जिन लोगों ने इस प्रक्रिया को पूरा मेल के द्वारा हमसे बातचीत करके इस मुकाम तक पहुंचे हैं, उनको भी मैं शुक्रिया अदा करना चाह रहा हूं। मुख्य रूप से हम लोगों ने जो बात किया है अपने इस कैंपेन के दौरान, वो है कि जो ह्यूमन राइट्स राष्ट्रीय नेशनल ह्यूमन राइट्स कमीशन ने एक 2018 में 13 पॉइंट्स का एक पेशेंट राइट चार्टर इशू किया है, जिसमें हेल्थ एंड फैमिली वेलफेयर मिनिस्ट्री के थ्रू उसको सभी राज्यों को भेजा है उन्होंने, इसको लागू किया जाए। लेकिन कई राज्य इसको अभी एक्सेप्ट नहीं कर रहे हैं। विशेषकर ये चीजें उस समय आई जब लॉकडाउन, पूरा देश लॉकडाउन से गुजर रहा था और पूरे देश में कोविड का पूरा दौर चल रहा था, जिसमें अस्पताल के लोग मरीजों को बाहर मतलब एक्सेप्ट नहीं कर रहे थे और बड़े ऊंचे ऊंचे पैसे मांग रहे थे, जिससे पूरा मरीज जो थे, जो पेशेंट्स की राइट्स सब पूरी तरह से धराशायी हो रहा था। उस समय हम लोगों ने NHRC को, राष्ट्रीय मानवाधिकार आयोग को कई प्रत्यावेदन, एक तरह से कई पेशेंट्स के राइट्स को लेकर के हम लोगों ने कई याचिकाएं फाइल की, और जो काफी इफेक्टिव रही हैं और कई अभी भी चल रही हैं, जिनको पनिशमेंट होना है, जिन अस्पतालों ने मरीजों को नकार दिया था। तो हम लोगों ने जो अपने पूरे 4-5 जिलों में जो ये प्रक्रिया चलाई थी, उससे जो लोगों में एक जागरूकता आई थी, उससे काफी मरीजों के राइट्स को हम लोग इंश्योर कर पाए थे। तो एक बार फिर मैं ISW काउंसिल के साथियों को और फिर जूरी मेंबर के साथियों को शुक्रिया अदा करूंगा, एक तरह से आभार व्यक्त करूंगा कि उन्होंने मुझे इस लायक चुना और हमारी संस्था को उन्होंने अवार्ड के काबिल बनाया। थैंक यू।
बहुत बहुत बधाई अंसारी साहब, बहुत बहुत बधाई।
आप अपना अच्छा काम जारी रखें अंसारी साहब, अवार्ड्स तो आते रहेंगे आपके पास।
बिल्कुल बिल्कुल बिल्कुल।
Let's now move on to the Gold Award for education and training for patient centricity and advocacy. The Gold Award for education and training for patient centricity and advocacy goes to MRKH India. Congratulations. I would like to invite Ms. Nehal Chaudhary to please receive the award.
Actually, I'm speechless. I can't say a word because I never thought that this award will be given to me. When I started, I would like to give a brief about this initiative. I started for a group for MRKH.
In the interest of time, we request you to please give
Yes, it will be a brief. Don't worry about it. So MRKH is really, I cannot speak, but I really want to thank, and you can Google it. But thank you so much for this award. Thank you so much.
Thank you, Snehal, and congratulations to MRKH team. Let's now move on to our next category, and this is the award for startups in patient centricity and advocacy, and this goes to Cancer Care. I would like to invite Dr. Sonal Rai to please receive the award.
Thank you very much. On behalf of Mrs. Anila Kothari, Chairperson Cancer Care Jaipur, which is an associated body of BMC HRC, Bhagwan Mahavir Cancer Hospital and Research Center Jaipur. The unit developed by a cohesive team of women volunteers, members engaged in selfless services to help and support cancer patients, effectively looking into minimizing the patient activities through various activities, patient anxiety through various activities, and also provide financial aid to the underprivileged. The outcome of these activities are people enlightened about cancer and are cancer survivors. Thank you.
Congratulations to all team members at Cancer Care who are doing a phenomenal job to increase awareness about this, to help patients find support from each other and from qualified professionals. So we'll now move on to the next category, that is patient advocacy groups. And the bronze award for patient advocacy group goes to the bronze award in the patient advocacy group goes to Lymphoma Support Group India. Congratulations. I would like to invite Dr. Shamim Khan to please receive the award. I would request Dr. Shamim Khan to please receive the award, or if any of his team members of the Lymphoma Support Group India, if any of them are on this call, would request them to please stay aligned to receive their award. We do have the Lymphoma Support Group with us. Would request you to please unmute yourself and receive your award. I'm afraid that they are unable to hear us, so we'll just move on with our next award. And this is the Silver Award for Patient Advocacy Group. The Silver Award for Patient Advocacy Group goes to Sachin Sarcoma Society. Congratulations. I'd like to invite Ms. Rashi Kapoor to receive the award.
Thank you so much for giving this opportunity to take this award. It's indeed a big feeling. I'm not able to digest the feeling that we are getting this award. So we really want to thank ISW Council for recognizing the efforts of our team that we have been doing tirelessly from 2018 to support, guide and counsel sarcoma, desmoid and GIST patients. We would sincerely like to thank Dr. Sameer Rastogi, All India Institute of Medical Science and Sarcoma Medical Oncology, all my team members, Lakshay Nagpal, Jyoti Yadav, Ashish Rana, Aarti Jain, Arzu. I would sincerely like to thank my family members for supporting me and this cause. I feel that though we have started from last 4 years, it's still a start. It's just the beginning and we have to go a long way to help. It's really inspiring to be there, a part of this meeting, and congratulations to all the people who have got awards today. So big thank you to ISW Council. Thank you so much for recognizing our efforts. Thank you.
Heartiest congratulations to the entire team of Sachin Sarcoma Society. Let's now move on to the Gold Award for Patient Advocacy Group. The Gold Award for Patient Advocacy Group goes to Thalassemia Patient Advocacy Group. Congratulations. We would like to invite Mr. Anuj Vadera, Videsh Piplani, Nehal Thingra, Anubha Tanisha Mukherjee to please receive the award.
Good afternoon. I'm really delighted to get this award on behalf of PPAG. Anubha just left, so she's leading the group, but she wouldn't. She had to leave because of some emergency. So I just want to say that blood safety is a topic which is important to all, not just meant for thalassemia. So we feel that safe blood is one of the fundamental rights. No one should get any transfusion transmitted infections because of a blood which is unsafe. So, and it is even more important for thalassemia patients who get blood every few weeks. So, I'm really glad that this topic has been highlighted by IHW, and I'm so thankful to the jury for choosing us and recognizing our efforts in this initiative. Thank you.
Heartiest congratulations to the entire team of Thalassemia Patients Advocacy Group. Let's now move on to our next category, which is Patient Advocacy Organization. And in the organizations category, we will start with the Silver Award. The Silver Award for Patient Advocacy Organization goes to the Silver Award for the Patient Advocacy Organization goes to Kidney Warriors Foundation. Heartiest congratulations. We'd like to invite Marianne Manise, Shantanu Saha, and Naval Joshi to receive the award.
Thank you, Marian.
Thank you very much, guys, for giving us this award. And it's such a joy and such a beautiful moment for all of us as a community, because I think kidney disease has been a disease you live a prolonged lifestyle, and the whole community is made up of dialysis and transplant patients trying to help families live better quality lives on dialysis, post-transplant medicines, insurance. And I think this award is very emotional for me personally itself. And I'm sure this is going to encourage us to do some better, greater work, come together as a community, as one voice, and inspire families on the journey of CKD. Thank you.
And we would like our founder, Vasundhara Raghavan, to say something. She's also here. So she is the one who founded this organization. Ma'am.
Thank you very much for this award, the recognition, and to know that our work is being recognized by the community and people feel the need for a patient, a body like Kidney Warriors Foundation, to bring change for patients in India. We've just started walking, so we need to now run. And we are happy that we have so much of recognition. And thanks a lot to the council for and the jury for considering us for this award. Thank you so much.
Thank you. Thank you.
Heartiest congratulations to the entire team of Kidney Warriors Foundation. Let's now move on to the Gold Award. The Gold Award for Patient Advocacy Organization goes to One Life, One Life Happiness. Congratulations. I would like to invite Mr. Saksham Kelu to please receive the award.
Good afternoon, everyone. So thank you so much, all the jury members and IHW Council for giving me this opportunity. On behalf of all the OLIH team and Dr. APJ Abdul Kalam Research Foundation, I thank you, everyone, and congratulations to all the awardees also. What I think that I'm still too young to hold this award because I'm a third-year medical student still. And see, the idea behind starting this initiative was, it was started in the month of July 2020. When I was saying that during the COVID times and especially during the first wave, the mental health cases were rapidly increasing in our country. So I was saying that the age group 18 to 24 were more prone to these disorders like anxiety and depression, etc. So I started this initiative with all my professionals like psychologists and psychiatrists. And what I think that these, like a lawyer and a psychiatrist or a psychologist, these two make a very deadly combination providing mental health services. So this was the idea behind. As soon as the time passes by, I also started giving the food drives, fundraising for the cancer patients also, and I also provided training to the interns and mental health patients to how to deal with further like in the life. So thank you so much for everyone for giving this opportunity. Thank you all.
Congratulations, Saksham. It's never too early to start. Great job and keep up the good work. Let's now move on to our next category, and this is patient advocates. Now, in this patient advocate category, we have the Bronze Award. So, the Bronze Award for patient advocate goes to we'll just give a minute for the visual to come. The Bronze Award for Patient Advocate goes to Dr. Pragya Shukla, HOD Clinical Oncology, Delhi State Cancer Institute. Congratulations. If Dr. Pragya is here, I request her to please say a few words for the award that she has received. Right. I think Dr. Pragya is not on this call, but we will share this recognition with her. We will send the award to her. Let's now move on to the Silver Award for Patient Advocates. The Silver Award for Patient Advocates goes to Padul Agarwal. I would request Mr. Gaurav Sharma to please receive the award on Ms. Agarwal's behalf.
Thank you.
Ms. Agarwal is with us. Congratulations, ma'am.
Thank you so much. It's really great honor for me. जब कैंसर पेशेंट्स या थैलेसीमिया पेशेंट्स बॉम्बे ब्लड ग्रुप नेगेटिव ब्लड ग्रुप्स को जरूरत होती है देश के किसी भी कोने में, तो हम अपनी सेवाएं देते हैं। ये अवार्ड मैं सभी वॉलंटियर्स के बिहाफ में एक्सेप्ट कर रही हूँ। सबकी तरफ से बहुत बहुत थैंक्स। एक पीठ पे एक थपथपाहट की जरूरत होती है। थैंक यू सो मच फॉर दिस एनकरेजमेंट। थैंक यू ISW काउंसिल जूरी मेंबर्स। थैंक यू।
Congratulations, ma'am, and please keep up the good work. We will now move on to the Gold Award for Patient Advocates. The Gold Award for Patient Advocate goes to AngelHealthline.com. I would request Mr. Gaurav Sharma to please receive the award.
Thanks a lot, ISW Council. So it is like great pleasure and an appreciation and recognition towards what we are achieving and what we are focusing on. So I would especially thank the founder Shubham Jain, who initiates this. And currently we in the pandemic area of the second wave, we helps around more than 20,000 per day traffic follower to our website. It is like really a great honor for helping and achieving, and it is not about it is like we would be a helping hand. It would be love. We would be love to do and continue this good work. Thanks a lot again. Yep.
Heartiest congratulations to all the winners, and request you all to continue with your good work, because this really impacts many, many lives. It brings about a positive change, and the work that you're doing is of innumerable benefits to those who receive the benefits of it. Thank you all for doing your good work, and congratulations for all the winners who are doing such a great job. As a health and well-being institution, we believe that all nominations received from the organization, institutes, and individuals were an act of humanity and have contributed remarkably to mankind to make our country more socially aware and pro-humanity. Kindly keep up with your great work. You're all doing an amazing job, and we are very happy to have you with us on this platform to recognize the awards, the work being done by you. We're going to wrap up the award ceremony, and congratulations again to all the winners, and congratulations to everybody for joining us this afternoon. Do stay tuned to ISW Council's Facebook page. We regularly update you about the latest trends and news on health, wellness, and fitness. And of course, you can also keep a track of all the shows and the programs that we keep doing on a regular basis. Take care, and good to see all of you. Goodbye.